All right, so I have to join.
All right, welcome everyone. My name is Krishna Udaikumar. I'm the Executive Director of Innovations in Healthcare, and it's my great pleasure to welcome you all to what is now our digital annual forum for innovations in healthcare. I want to acknowledge that this is a difficult, uncertain time for many of us around the world as we deal with a situation that's changing by the hour and by the day with the COVID-19 pandemic, and we want to be sensitive to that. And we'll certainly try to address some issues that are relevant for all of us that are trying to take care of our loved ones, our communities, and our patients as we go through the next few days and weeks. We also want to thank all of you for engaging with us. We know that for many in our community, our regularly scheduled annual forum in person is a highlight of the year and an opportunity to really make connections and build stronger collaborations. On 6 days' notice, we're going to do our best to try to create a compelling digital experience over the next day. So we thank you for joining us, and also thank you in advance for your patience as we work through what you see as our improvised studio here, which also serves as our conference room. So thanks for being part of our community. Thank you for joining in, and let's get started. I want to spend just 5 minutes giving you context and background for what we're going to do today and tomorrow. And I'll start with our next slide by reviewing who we are and what we do. So as Innovations in Healthcare, our mission is to increase access to quality, affordable healthcare worldwide by scaling leading innovations. And our vision is a world where innovation improves health for all. And we think that's as timely as ever with the state of the world today. One of the major ways in which we operate is to scout for and curate some of the best health innovations around the world. And to date, we have amassed an affiliated network of 99 innovators operating in over 90 countries. You'll hear from some of the newest members of that network over the course of the next couple of hours. In 2011, we were founded by Duke Health, McKinsey & Company, and the World Economic Forum, and we're hosted at Duke University in North Carolina. And we partnered closely on the Duke side with the Duke Global Health Innovation Center that allows us to deepen the evidence base, advance policy analysis, and also to expand our education training and capacity building. Next slide. As I mentioned, you'll hear today from the newest members, our 2020 Innovator cohort, which are focused especially on applying advanced principles of digital health and data science to improve health and healthcare globally, as well as some leading models that are addressing the growing burden of mental health in different parts of the world. You'll see the logos here on your slide, but you'll also get to hear directly from them. And so we'll get straight to that in just a couple of minutes. What we do across Innovations in Healthcare, as well as the Duke Global Health Innovation Center, is really focused on different ways to scale innovation to improve health worldwide. So everything from sourcing, strengthening, studying, and scaling health innovations, designing and implementing, as well as evaluating global health programs, trying to create and share regional market insights, delivering capacity building and training programs, convening ecosystem leaders to develop breakthrough solutions, and also developing and implementing evaluation tools to help measure and improve impact. What can you expect today and tomorrow? Well, today we're going to have two major areas of emphasis. The first is to introduce the 7 new members of our Innovators cohort in 2020 and part of our broader network. And secondly, a timely discussion on addressing mental health challenges that will be from 11 to 12 today. And then tomorrow, please join us again. We're going to have 3 major topics of discussion. The first is on innovating primary care for value. The second on how we can better deploy the principles of data science to drive value in healthcare. And the third, a timely discussion on COVID-19 and innovation from some of the leading thinkers operating in this space. And we're going to use this opportunity that we've gone to a digital format to think about how else we can stay digitally connected with all of you and many others as we go. I want to take a moment to thank all of our sponsors. Our work wouldn't be possible, this digital event, as well as our coming in-person events down the line wouldn't be possible with all of our sponsors. So Amgen, the Pfizer Foundation, Dynamic, Takeda, Bayer, Grameen Digital Health. Thank you all for the sponsors. And then next slide, you'll see more of them. Janssen Neuroscience, RICO, Linked Foundation, and our strategic partners, the U.S. International Development Finance Corporation, as well as USAID. So before we get started with the next session, just a few reminders. You'll see on the Zoom webinar format that we're using that you have 2 buttons on the bottom. One is a chat function and the other says Q&A. Please use the Q&A function to send questions that will be answered by our panelists and our speakers as we go. The chat function you can use to report any technical issues to our IiH team. You can also send messages to the panelists or to all of our attendees, but for more engagement opportunities, please do also engage through the Whova app. You will have, when you registered for the event, gotten the instructions on how to get to the Whova app to our 2020 Digital Forum event site. You can post on the chat function here if you need help in activating that, but Whova will give us an opportunity to engage in much more substantive and dedicated ways. Our hashtag for the event is IiH Forum 20, which you can use on social media when you're talking about the conversations here. So with that, it's my pleasure to welcome one of my team members, Judd Staples, who serves as our Assistant Director for Partnerships and Engagement, to lead us in our first session to hear from our 2020 innovators. Over to you, Judd.
All right, thank you, Krishna, and good morning, everyone. Thanks for joining the annual Digital Forum with us. My name is Judd Staples, as Krishna said. I'm the Assistant Director of Partnerships and Engagement. Next slide, please. So for the last 9 years, Innovations in Healthcare has been sourcing leading innovators from across the globe that are having an impact on human health. Our network of innovators are working in all parts of the healthcare delivery system, from workforce training, care delivery, products and technologies, and system support. Currently, our network is at 99 different companies across the globe in more than 90 different countries. This year, we're pleased to introduce the 2020 cohort to the Innovator Network, 7 companies at the forefront of mental health and digital health. Next slide, please. So we'll be starting off the session with 3 companies in the digital health space, followed by 4 companies that are leading the way in mental health, also leveraging digital health technologies. We'll be giving each of our innovators 10 minutes to talk. We'll have an opportunity to field questions to them after each of their talks. Please feel free to enter those text or those questions in writing using the Q&A button, and we'll get to them at the end of their session. So our first innovator is Dimaggi. Dimaggi is represented by Jonathan Jackson, the CEO.
Great, can everyone hear me?
Yes,
Yes.
we can.
Great, thank you so much. We are incredibly thrilled to join the network, and we are one of this year's innovators. I want to give a quick update on Dimaggi as mentioned, and I will close with talking about some of our COVID work, which I know is top of mind for many of us. Dimaggi is a social enterprise founded back in 2002 out of MIT and Harvard, and our mission since day one has been to create sustainable impact for underserved populations. We highlight sustainable impact now because this used to just say impact, and as the field of digital health has grown and matured, we are incredibly excited by the major amount of impact that has been proven in numerous studies. But we now view it as part of core to our mission to make sure that not just Dimaggi is sustainable as a social enterprise, but that our entire field makes sure it's building digital health and partnerships in a way that is going to create sustainable impact. And that sustainable impact for us is making sure that we can support people like Marilee. She's our target user, and she's a frontline worker taking care of her community in a rural or urban environment anywhere across the world. She helps pregnant mothers have safer pregnancies. She helps refer people to clinics as needed. And after delivery, she helps make sure that the newborn and young children in the household get the care and support they need. She's a very difficult job. She's often underpaid. She's often undertrained. And therefore, we believe technology can have a major supportive effect of her role. But it's important to note that we view technology not just as a tool, but as an augmentation and a force multiplier for the workforce. We need to make sure we're investing in frontline workers, be it community health or at the clinic level. And there's no greater evidence of this need than today with our global pandemic that we're seeing and the major impact that frontline workers are going to have in both the surveillance and response of these efforts. The way that we support these frontline workers is through our global good open source platform called ComCare. We've been developing ComCare based on our experience over the last 18 years, and we've been building it as an open source product for the last 10. There's three key principles that we've taken in building ComCare to make sure that it supports the frontline workers like Marilee. The first is to make sure we can build comprehensive mobile applications in a no-code environment. That enables non-programmers, non-technical staff to build sophisticated mobile applications. And importantly, we make sure that these can track data over time. This is critical because it's not just about one-time data collection. It's about making sure that we register a household, register a patient, track their health over time, and make sure we can both do health promotion activities as well as service delivery improvements when we're managing care. And finally, we've taken these two key features and made sure they work offline. The ability to work offline has taken an immense amount of engineering capacity on our team, and it's something that most other big technology firms do not design for. And therefore, many of the products like Salesforce or others that work incredibly well in connected environments do not work for users like Marilee. And when we take these three features together, we're able to fully build an empowering community health worker with counseling, performance monitoring, and multimedia. These sets of features have enabled us to gain rapid market share. We now have an estimated 1 in 10 community health workers in low and middle income countries digitally equipped with ComCare. This has been a huge accomplishment, but it means we still have 90% of the way to go. In our current state, we have over 400 million people registered with ComCare. And we believe, as I mentioned, with sustainable impact, it's not just about the fact that we got to this scale, it's now about what can we do with this scale and continue to improve it and continue to improve the impact that our users have. But it's not just about the scale. Those 400 million people are being actively supported by 680,000 community healthcare workers. But as I mentioned, there's 90% more that we need to get to. But often the digital community and the digital health community view scale as the end goal in and of itself. And that's not what we're trying to do here. We're trying to create long-term sustainable impact. So the two other dimensions that we've been incredibly excited by is both the validation of the use of ComCare in the field. We have over 65 peer-reviewed publications, including 8 randomized controlled trials, showing the value of ComCare in a variety of environments. These use cases span TB, HIV, malaria, cardiovascular disease, and a variety of other use cases. And these studies do not just further the benefit of ComCare, they further the entire field. One of the stats that we're most excited about, though, is our sustainability. As I mentioned, as a social enterprise, we've really struggled with the business model that applies in global health and that can both allow for a for-profit social enterprise to scale as fast as possible. And we've had rapid growth in our SaaS platform, which is users supporting ComCare on their own, not hiring our professional services team. And that growth is really key to our sustainable business model. So when we combine these three areas, we have sustainable business and product, we have a highly impactful product, and we have one that's scaling rapidly. This allows us to then create proven interventions that health systems want to adopt and scale up. And we can see three key dimensions of that evidence base. Healthier patient practices, where 73% of users, of patients were more likely to attend 3 or more antenatal care visits. Improved patient outcomes, where we saw an 18% decrease in maternal mortality and a 48% decrease in infant mortality. That study, though, it should be known, it was not just ComCare, there was also telemedicine happening through the phone, which was a critical enabler of this outcome as well. And finally, the cost effectiveness of the intervention. Health systems need to be viewing digital technologies and digital health not as IT cost centers, but as full health systems interventions that have positive ROI for the outcomes they achieve. And we're thrilled by all the success that we've had and the ability to quit merrily, but it's not enough. What we're doing is never going to achieve universal health coverage if we continue to try to work on our own, which is why we're so excited to be part of the IiH network. And one of the things we're doing is not just expanding our current business, which is digitally enabling CHWs, but it's where we want to go tomorrow through technology and other partnerships. And that's about not just fully enabling the other 90% of the digital CHW workforce, but digitally enabling patients. If we think about how much care needs to be shifted to community healthcare workers and then augmented by what patients can take care of on their own, it's critical that we make this jump to self-care and digitally enabling these patients. The three new innovative areas that Dimaggi is working on today as our next generation of products, the first is direct-to-client interventions and innovations. These are things like chatbots or conversational AI, where we can take the data collected by the community healthcare workers at the community and create an interactive experience, drive improved outcomes and improved knowledge and understanding by the patients themselves. So if I know that I just labeled you as high risk on my last home visit, I can then send you conversational content to make sure you know it's very important that you go to the clinic on your next visit and answer any questions you have. And this is a huge force multiplier for the very limited healthcare resources that we have at the last mile. The second is making sure things that are very mundane, like device security and data security, are taken care of. As these digital health projects scale, we have a underwhelming approach to how we do IT security in the field. And a lot of the basic products that enterprises have taken for granted in more developed markets are critical. And we've done a landscape analysis of many of these types of interventions, and they're not appropriate for offline use cases. So Dimaggi is also taking it upon our product strategy to build products that work well in an offline mode, like our Focus device management product. And the last is data science. This is an area that many, many people are working on, and we have a panel on tomorrow. But it's critical that as we scale these digital health interventions, we're fully making use of the data, both for primary use cases to improve the program and secondary use cases. For example, all the community healthcare workers that are equipped with ComCare, some percentage of those are taking status of whether you have a fever in the home. And that is an early indicator for disease outbreak detection, but that data needs to get to the right place and be analyzed by epidemiologists. Those types of secondary use cases, we believe, are critical going forward to make sure we're unlocking the full value of digital health on our platform. And the final slide I want to close with is just what we're doing on COVID-19. As I mentioned, the three key features of our platform, the ability to rapidly build applications, work offline, these are critical for COVID as well. And so we've been rapidly building template applications, just like we did with Ebola. We're making the platform entirely free for COVID-19 use cases, and we're deploying it to through our partner network and with any new partners that need to request it. So if you have a COVID-19 use case that you rapidly want to move on, please feel free to reach out to me, and my email's at the bottom there. Thank you very much for your time.
Thank you, Jonathan, for that overview. I'll remind everyone to use the Q&A button for questions for Jonathan. You mentioned partnerships in your slides. Can you tell me about some of the more valuable partnerships that Dimaggi has entered into and what's on the horizon?
Yeah, so we've worked a lot with academia who partners on our studies and is helping us think about, from a secondary use standpoint, What are the interesting data science questions? Our technology partnerships with organizations like Tableau and Prekelt, who's a South African-based organization that rapidly built an amazing chatbot on WhatsApp to bring in that messaging component. We've been talking with other organizations in this year's cohort, actually, with Babylon, WISA, and others around how we could potentially partner on their direct-to-consumer areas. And so for us, it's really about understanding what are the other technology approaches that can provide more value. If we look at the market landscape, community healthcare workers, I think it's a kind of a given in the global health community that people think digitally equipping CHWs is a good idea at this point. And we've benefited from that. But unlocking the digital value of putting in these relatively expensive platforms, equipping them with smartphones, unless we're connecting these to all the great other innovations that are happening, I think we're going to really fail to unlock the potential value there and frustrate a lot of the governments that we're trying to support.
Thank you, Jonathan. There is one question, though. I'm not sure. We have a question about getting a little bit more detail on the COVID-19 use case. Can you expand on that a little bit further?
Yeah, so if you are doing contact tracing or surveillance or self-reporting, those are all use cases that can be supported in ComCare. So our team's been working for the last 2 weeks on building template applications that support the standard WHO forms. There's protocols for when you have your first few cases. That then shifts into more of a containment mode where you might only need to follow up on people who have been actively diagnosed or persons under investigation. And then you're going to move to a mass mobilization of self-quarantine and social distancing. All of those types of use cases can be built on top of ComCare and rapidly deployed. And so we're working with our partners to do that in environments where they've already equipped community healthcare workers. And then some are rapidly deploying new devices or only messaging-based approaches, which can use your existing devices in a lot of environments. And so we're working both here in the United States and globally as well.
Outstanding. Thank you. So we have another question is, how do you work with Ministry of Health in different countries, and in what countries are you working?
So Dimaggi is in over 70 countries right now with ComCare as a platform. We have offices in Cape Town, India, and teams spread in other countries like West Africa, in Dakar, and Rwanda. Our partnership model is either to build up a direct support team with the government where we do and have a local presence and are requested to by the government. But more often we're working through an implementing partner who may be doing a variety of activities, not just digital health. So a lot of our international implementing partners who work with many of the sponsor organizations of innovations in healthcare, like USAID, the Gates Foundations, and other, we will work with them to provide our platform, and then they will work with the government to deploy it. And that model has worked incredibly well for us in scaling up.
Outstanding. Thank you, Jonathan. We have another question about, do you have products that support clinic management, or are you focused on the clinical health worker level?
Yeah, we do support clinical management. So we have for use cases where ComCare is deployed at the nurse level for triage and diagnosis. In Burkina Faso, we're at 60% of the clinics with an organization called Terre des Hommes, who built the entire integrated management of childhood illnesses on top of ComCare. So a very robust algorithmic protocol. And that has allowed us to scale rapidly, improve training, improve consistency. It is not an EMR though, so at some point you want to flip into a more rigorous data model and clinical approach. And there are open source products such as OpenMRS or proprietary EMRs that we can then integrate into over common standards like IiH.
Great. Well, thank you very much, Jonathan, for your presentation. I think that's all the time we have for questions. We want to move on to our next innovator. The next innovator in our cohort is Babylon Health. Representing Babylon Health is Claire Morris, International Programs Director. Claire, are you with us?
I am with you. I am with you from London. Just 1 second. Has the screen sharing worked?
Not just yet. We have the slides on hand if necessary.
Okay.
Perfect.
Perfect, great. Thank you very much. It's a real pleasure to be joining you and to be joining the cohort, and really exciting to hear from both the other innovators who are joining with us at the same time, as well as your existing cohorts. So thanks very much. So I'm representing Babylon Health. We are a UK based digital health company, founded with a mission that I know will be in absolute alignment with everybody else on this call, and very much in alignment with the Innovations in Healthcare network. So we were founded in 2014 to make healthcare more accessible and affordable, and really using mobile technology, digital technology, and AI to try and reduce cost and increase accessibility of healthcare worldwide. This just gives you a quick sense of the size of the organization. As I said, we're UK founded, starting to grow into a number of other countries. We have a large team, nearly 2,000 now globally, in a range of different locations, and we are in our sort of Series C funding round. So Babylon has taken the model very much of thinking about users, patients, customers, however people think about it, at our center, and what type of healthcare needs they will have throughout the course of their life, whether it be from when they're sick and needing to understand their symptoms and needing specific healthcare services, through to supporting people when they're recovering or managing a longer term chronic condition, as well as to how people stay well and healthy. So we're looking at kind of this whole circle of everything that's comprised in healthcare, and looking at what we can do and address initially through somebody's mobile phone or via AI models and tools, through to then virtual services, i.e. telemedicine, and obviously the referral into physical services to ensure really appropriate customer and patient journey, and an integrated and holistic approach. So what it looks like, and I'm just going to initially refer to the way in which we're working, for example, in the UK, where we kind of have our full model up and running. This ranges from as an entry point, and we have an app which is available and free for anybody to use in the UK, which has an AI symptom checker, which is we have a huge team of data scientists, epidemiologists, and doctors and engineers who've worked on an AI model. And the entry point is a symptom checker, which asks questions and interprets your symptoms via a chatbot interface to give people recommended actions as to what they need to do next. That can then link in the case of the UK, we have a telemedicine service, which is both private for corporate and insurers, but also very importantly and increasingly at this moment in time, we run that service for NHS registered patients as well. So people can book a consultation and have a consultation with a GP anywhere they are. And as it happens, our GPs obviously are able to provide those consultations from home. We also have a health check or a health assessment, which takes somebody through a series of questions to develop a kind of a holistic view of someone's health, including their history and their family history, to then give them an assessment of the current their current health status, their risks, and some recommended actions for improving their risk, mitigating those risks in the longer term. And we're moving into, we now have a health management platform focusing on longer term chronic condition management, starting with diabetes, with a whole personalized care plan to support people in a holistic way with a condition like diabetes, ranging from obviously their nutrition to exercise to their consultations and appointments. What we've been doing is we have this sort of integrated and holistic approach, but we work differently depending on the market and depending on our client. So just to give you a few examples of the way in which we're working in Southeast Asia with a large private insurer called Prudential, and we have adapted two of our products to fit in within their health ecosystem. And so that is a kind of localized for 11 countries in Southeast Asia, localized by epidemiology, by language, by cultural appropriateness of the language, and also by for the sort of recommendations and the actions to understand the health infrastructure in each country, so that the type of actions that our AI will recommend will depend on what type of services are available in any individual country. Second one is our relationship with TELUS, a large telecommunications provider in Canada, where we have a joint offering, both of our AI as well as with with GP consultations, which are funded through the Canadian health system. Here in the UK, as I mentioned, we work very broadly, including our large GP at Hand, which is a virtual GP service working to support the National Health Service. And then we have an adapted model for our service in Rwanda, where we are actually using feature phones, and we are integrated within the National Health System, which I will refer to in a little bit more detail now. So just to underscore the importance, and I think this reference is actually a question that was raised during my colleague from Dimaggi's presentation, which is around regulators and standards. We obviously adhere to all the regulations and standards that currently exist for these types of products, both in the UK and in every single market that we go into. And indeed, our AI and data science team have been engaging with WHO and ITU, who actually have a working group on building sort of international benchmarks for symptom checkers. So not only are we adhering to everything that currently exists, but also engaging to try and support the ongoing evolution of regulation for these types of tools and products. Babylon's second country after the UK, which is, I guess, a sort of slightly unusual thing for a commercial company to do, was to go to Rwanda. We were invited into Rwanda by the government of Rwanda because they are a very visionary government with a very clear idea of what they wanted to achieve in terms of universal health coverage and how to leverage digital technology to support them in their ambition to provide quality healthcare to everybody in the country. So we set up, in essence, a telemedicine service in Rwanda, based in Kigali, where we have a call center with nurses and doctors and call center operators to really maximize those health resources for the most people across the country in all socioeconomic groups and all regions. So we set up in 2016. Since then, we've registered over 2 million people in a population of 11 million. The team have provided over 1 million medical consultations and trained a wide range of people, from doctors to nurses through to teams working in health centers. And very excitingly, and this is hot off the press, only a couple of weeks ago, we signed a 10-year contract with the Rwandan government for provision of health services through our model, with reimbursement from the Rwandan Social Security Board for greater integration with the system, as well as starting to use our AI in the call center as a triage tool. So the way it works is, as I mentioned, we're using feature phones in this particular case. So we have a simple USSD app. It's very quick and easy for people to register. We have integrations with the National Identification Agency and the Rwandan Social Security Board. Once somebody is registered, they can then request a triage consultation. That's usually within 5 minutes that they get a call back from the triage consultation. The nurse goes through what somebody's specific issues are and ensuring that they are quickly referring them to a district hospital if it's an emergency, to self-care if that's appropriate, or for an onward consultation with us if it's within our license. They would then get a call back either from a senior nurse or a GP for a full consultation. We're integrated within the public health system. So if somebody needs a prescription or a lab test, they get a unique code sent to their feature phone, which that can then be redeemed at a number of facilities across the country. And this gives you the sense of the coverage that we have. We've integrated with over 418 health centers, public health centers. These are health centers in Rwanda, where our portal is available within the health center. The teams have been trained so that the patients can access their medication and lab tests should they require and get the relevant follow-up. Obviously, partnerships here have been absolutely critical, and it's a range of partners across the health system. In the case, the health system and the sort of foundational teams such as Ministry of ICT and the Rwandan Development Board, as well as private sector providers as well. Very important, obviously, to understand from an external perspective who it is that we are serving, as well as how our patients view our service. And we did we contracted Dalberg with support from the Gates Foundation and USAID to do an impact evaluation last year to help us understand both how our service compared to conventional care, whether we were really making a difference to the speed at which people were accessing care, and also who were we reaching? Are we really having the extent of accessibility that we were aiming for in terms of both gender balance, the age of our patients, and obviously a representative sample across socioeconomic groups. And we're very pleased with that coverage and hoping to do even more under our new contract with the Rwandan government, which is where they're funding us to provide services to everybody under the Mutuelle scheme, which is the poorer segments of the Rwandese population. Now, in terms of where we go next, and I'm focusing more on our work where we're reaching more underserved populations as opposed to our sort of more commercial expansion, which has gone into the US, extending across Southeast Asia and the Middle East. We're looking at other countries where we feel that we could be working with governments primarily to enhance national health systems and to support them to achieve universal health coverage in a cost-effective way. We've been looking obviously at critical components of each market and really looking within this network to really get additional advice and support, as well as potential partnerships to help us look at expanding into other countries where digital technology could really enhance a national health system in this way. But we're also looking at kind of our overall global product roadmap, how that product roadmap can be adapted for lower income groups, how we can leverage partnerships to look at ways to use our technology, particularly our AI tools, to support existing organizations that are working with underserved groups, and how our technology can support the infrastructure and further enhance the services that can be provided to extend more customer-facing AI tools to increase accessibility and quality of healthcare. Thank you very much.
All right. Thank you, Claire. We have a number of, we don't have a whole lot of time for questions for Claire, but I can maybe ask one or two. One question is, what's the revenue model? Do you charge per user, per transaction, or something else?
So the model varies depending on the market and depending on the payer. So in the UK, for example, where we're working with the NHS, we obviously work on a capitation fee. So it's per registered patient per year. Where we're working in Rwanda, that's going to be on a per consultation basis. And then where we're working with private providers, let's say in the case of insurers with Prudential, that's on a license fee, and that's based on a model of per user per year. But in most cases, we have obviously a few private subscribers to the service in the UK, but mostly it's the service is usually free to the user, but they are being covered by a payer, which might be a government, might be an insurer of those kinds.
One participant asked, have you reached a break-even point, and if yes, how long did it take?
It's a good question. The answer is we're expanding so fast that no, not yet, because obviously, like many technology companies, we've been continually investing in our expansion, both geographically as well as in our product. But our team in Rwanda have been doing very well in this regard. And maybe if you want to contact me separately, I'm happy to share a bit more information.
Great, thanks. And one final question, I guess, is sort of, you've got an audience here, or the IiH network community. I guess how can the network help Babylon expand? Yeah, in their strategy.
Yeah, so, and as I kind of referred to in my kind of final two slides, I think we're looking at two things. One is obviously where we can where we can go into other countries and look to sort of replicate what we've done in Rwanda. So looking really at a sort of national scale services. So really insights and views of others as to which countries they feel are sort of readier for these types of interventions. And then secondly, and very much coming to the point that, Dimaggi made as well, of kind of where others in the network see that our technology could be integrated, could help enhance, or could, complement what they're doing, and what are those sort of opportunities where they've already got reach, infrastructure, users, community health workers, really excited about, conversations with Dimaggi and others in the network about those sorts of opportunities for partnership.
Outstanding. Well, thank you so much, Claire, for presenting Babylon Health. We're going to move on to our third digital innovator in the cohort, Maternity Foundation, and representing Maternity Foundation is Tara Televacchia. Tara, are you with us?
I am. Can you hear me?
I can hear you fine. Looks like.
Perfect. All right, I've selected share screen.
Looks like we're seeing it now.
Great. So hi everyone, I'm Tara Televacchia. I'm representing the Danish nonprofit Maternity Foundation, and I'm the manager of partnerships and strategy. And I just want to say thanks so much to the conference organizers for making this all work on such short notice. So I'm going to share a little bit about our intervention, which is the Safe Delivery app, by telling a story. And it's not just the story of one person or one healthcare worker, one beneficiary, but actually the story of a place, which I think is in some ways very unique, but also exemplary of some trends we're seeing at national levels in India and at global levels in health. And this is the story of the district of Mewat, which is in Haryana state in north central India. And we were told recently at Maternity Foundation on a visit that this district is 60 kilometers and about 60 years behind New Delhi. And this was something that was said to us by the director of a district hospital there. And Mewat has a very high level, a high portion of its population that are Dalit, the lowest untouchable caste, and a majority Muslim population. Most people there work in agriculture or truck drivers, and access to basic services such as clean water, sanitation, and hygiene are very lacking. And in addition, women have on average 5 children. But at the same time, right, there's a lot of development challenges, obviously, in this district. But there has been a stunning increase in institutional deliveries in Mewat, from about 40% in 2005 to about 70% in 2015. And this trend is actually something that you can see in India at a national level and at a global level as well. And in Mewat and in India, a lot of this is due to the fact that, for example, there's the world's largest conditional cash transfer program, JSY, that drove women in increasing numbers into facilities. So the question then becomes, with this stunning increase in the supply side showing up for care, can those in these clinics and hospitals meet this demand with quality care? And several studies of JSY and other programs that were implemented by the government of India with the intent to drive women into facilities to give birth actually found that there were urgent efforts that were needed to really increase the competence of birth attendants to manage obstetric complications for these women that were showing up for care. So one of the programs that the government of India implemented to try and tackle this quality of care issue was called Laksha. And Laksha has several components, but the one that the Safe Delivery app fits into is this enhancing the knowledge and skills of staff to provide quality intrapartum and intermediate postpartum care, as well as the timely management of complications and appropriate referral management. So in comes the Safe Delivery app. So the Safe Delivery app is a free app for smartphones or tablets that provides skilled birth attendants. So this varies a little bit country to country, but these are trained medical professionals, normally midwives, nurse midwives, They can be doctors in some cases, but they're trained medical professionals with instant access to evidence-based clinical guidelines on basic emergency obstetric and neonatal care, as well as a selection of essential preventative protocols. And the app was developed by Maternity Foundation together with 2 different universities from Denmark, where we're headquartered, and launched in 2015. And the idea for the Safe Delivery app was born out of our on-the-ground, fairly traditional NGO that was operating in Ethiopia that was focused on training healthcare workers and how to handle emergencies. And we saw a real gap and a real need for a tool that could take these guidelines and make them simple, easy to understand, highly illustrated for low literacy settings, but also in addition to just being used in training, that could be something that was easily accessible at the fingertips of skilled birth attendants when emergencies did arise. So the app contains videos, action cards, practical procedures, a drug list, and My Learning, which is an interactive learning platform that allows users to go on a self-guided learning journey based on what they know, what they don't know, what they want to brush up on, and eventually earn a certificate that they've passed all levels at the desired level of proficiency. So the app is used in a variety of settings. It's used in the health facility. It can be used in pre-service education, so at midwifery, colleges or nursing universities. It can be used in in-service refresher training, and it can be used in facility-based mentorship programs like Laksha. And I think I mentioned already, it's used as a job aid. Skilled birth attendants use it to review and refresh their knowledge, to look up dosages while they're on the job, if they have time. As a study aid, it helps support in simulation drills, but also in the classroom, so in practical settings and in hands-on settings. It's also a teaching tool. We've heard from a lot of teachers and mentors that the app actually helps them break out of delivering slide after slide after slide and allows them to change their teaching methodology a little bit to be more hands-on and more engaging. And also it's used, as I mentioned before, as a self-directed learning tool. So back to Mawat, what have we seen so far in Mawat? What has been the impact of the Safe Delivery app there? So we've heard that, you know, nurses are much more confident now. They know how to stabilize patients. And actually there's been a change in the number of patients who've had to have been referred from clinics to the hospital level. The nurses actually work more according to protocol now. We've heard this in a number of settings. There's a lot of disagreement just because of the way trainings are administered, but also time passes and people forget what to do in emergency situations. So there's often a lot of disagreement and deviation from protocol. And we found that the Safe Delivery app helps adherence to protocol. And then we've heard from the nurses at the primary health center there that their degree of knowledge has increased. They really talked a lot about infection prevention in particular as a subject that they brushed up on, which is a huge concern when you have a ton of patients coming in all of a sudden to your facility. Infection prevention is a huge issue. That they also confirm at this level that the nurses feel that they're able to refer less and stabilize patients better before referring them. And that they have something to guide them when they don't remember a drug dosage or how to handle a particular case. So in addition to this qualitative data, you know, what else can we see? You know, this is all fabulous, but the great news is we can look into the back end of the app, and we have a data dashboard that pulls data from the Safe Delivery app. And so we can see what is engaging users in terms of content, in terms of feature, and we can see the development in app usage over time. And for example, in the case of Mawat, there's 53% of users are highly active. So that means we've set specific metrics in the amount of time that users are spending on the app and in the number of features. So we can, in this way, see a lot of what we've heard qualitatively matches up what we can see quantitatively. We can also see learning progress and gaps in competencies. So this actually, they're kind of small, but the charts below show the average user journey through My Learning, content and levels in Mawat. And so together with the qualitative data, we can start to generate insights in healthcare workers in Mewat, for example, know, what they don't know, what they're striving to get better at, and feed that back into decision makers and training and learning. So zooming back out of Mewat, we have a huge champion in India who is Dr. Dinesh Baswal, is the Deputy Commissioner for Maternal and Newborn Health at the national level. And he's the one that reached out to Maternity Foundation and said, we want the Safe Delivery app in India. And we worked very closely with him and his government in Topigo to create the app for India. And since then, we've seen about 65,000 downloads in 10 states since 2017 when the app was launched in December of that year. But in addition, I think Dr. Boswell's point about the stickiness of the app, how busy people are, the stress in the labor rooms, but that once people are on the app and are learning on the app, they're hooked. So panning out a little bit more, our global impact, the case of Mewat, I think is pretty exemplary of how the app is adding value to quality improvement efforts in maternal and newborn health around the world. We have 20 plus implementing partners in 15 countries, over 130,000 downloads. We have over 12 different versions of the Safe Delivery app. You just saw the one for India, but our impact is much broader than just what I've highlighted here in Mewat. And finally, where are we headed? So Maternity Foundation, I think I mentioned at the beginning, started as an on-the-ground NGO in Ethiopia, really focused on training. And since then, we've taken that into the space of digital training and digital learning. And we've seen that this is a really niche space in digital health. There's not a lot, it seems, not a lot of apps that are focused really deeply on learning, and not a lot of organizations that are bringing together both digital learning and in-person learning to bring about blended learning. So we're trying to figure out how we go beyond the Safe Delivery app to look at adult learning more broadly in this space. And I welcome suggestions and questions in that regard and about anything else. Thank you so much.
Great, thank you, Tara. We have a few questions from the audience. One is the app available in Urdu for use?
No, not yet. No, not yet in Urdu. But we have a strong clinical team that is open to exploring different language versions and can speak with whoever is interested.
Gotcha. Another question is, do you have any license or accreditation to offer health education? Or do you need any?
Yeah. So some of the organizations that we work with do. So for example, in Ethiopia, we work very closely with the Ethiopian Midwives Association. And they, together with the Ministry of Health there, have used the Safe Delivery. The Safe Delivery app is part of the official in-service basic emergency obstetric and neonatal care training program for all midwives in the country. And that program is accredited and the Safe Delivery app is embedded into that, but we haven't yet had to do that ourselves. Our partners, such as the Ethiopian Midwives Association, they handle that kind of thing.
Outstanding. Question about objective evidence. Do you have any objective evidence healthcare outcomes with maternity?
Yeah, so we haven't gone to healthcare outcomes yet for a few reasons. So I think on the previous slide, you saw that we've conducted 2 different RCTs, one in Ethiopia, and we had a partner do one in DRC. And those focused on improvements in skills and knowledge and confidence of skilled birth attendants, which is really our the primary outcome that we're focused on. It's a bit of a leap to say that it's hard, right, to prove that skills and knowledge and confidence have an impact on health outcomes. I think the next level of research that we're really interested in is implementation science. How does a Safe Delivery app impact those things in a non-controlled setting, and how does it add value in these large-scale quality improvement programs? I think the health outcomes, if we're going to look at mortality and morbidity, it's pretty tricky to make that leap, but open to exploring it in the long term. Outstanding.
Well, I'm afraid we've run out of time for additional questions. Tara, if it's all right, we might email those questions onto you, and you can answer them directly. But thank you, so much. So now we're going to move on to our mental health cohort. And first up is Maya Appa, and representing Maya is Ivy Hook Russell, founder and CEO. Good morning, Ivy. Can you hear us?
Hi. Yes, I can hear you guys now.
Great.
So can you hear us? Can you hear me?
Yep, we can hear you fine. Yeah, if you
Okay.
go into presentation mode, we can see the full. We're seeing your desktop now.
Can you see my presentation?
We see your desktop. If you could go into presentation mode. Perfect.
Okay, great. Sorry about that. So hi, everyone. I'm Ivy. I'm the CEO and founder of Maya, starting my day here in California. So I'm really excited to be here. I'm just going to jump into the deck because we don't have much time. So just wanted to highlight or start with what Maya's mission is in terms of to be Maya. At Maya, we're branded as the digital wellbeing assistant. But technically what it is, a user has a question, they type up their question on their app and our AI figures it out and matches it to the right expert while understanding the complexity, the urgency, the type of the question. Maya started from a very personal journey whereby two personal journeys of mine and my mom's. Maya is actually my mom's name. My personal journey when I was pregnant myself, while working in London, I used to visit Bangladesh a lot, and I realized there was lack of space where people could ask questions freely without having the fear of judgment towards, asking a very private questions. And of my mom's, who was coming out of breast cancer, she fell into a bit of a depression cycle where she was ashamed almost to go and see a counselor, again, simply tied to the social stigma and taboo around cultures in Bangladesh and neighboring countries. So that made me start the blog Maya. For a year or so, I continued the blog while I was working, but very soon I realized it was a one-sided dialogue or a conversation. I wanted it to be a two-sided one, and almost on a whim, I placed a call to action box, and that became like the service that we have now, from what it used to be about 10 questions a day to roughly around 3,000-4,000 questions a day. Just quickly going through some of Maya's traction. We right now, from that journey, from that story onwards, we now have about 2 million monthly active users, around, as I said, 4,000, 5,000 consultation every day. We have about 200 on-demand licensed experts in our network in Bangladesh, and slowly more in the network out of Bangladesh as well. Just a little bit of highlight here in terms of why a platform like Maya is needed in countries like Bangladesh, where the patient to doctor ratio is 4,000 to 1. And the psychiatrist to patient ratio is 1 to 1 million. Clearly, there's a lot of need for scale and technology, and obviously having these experts being available on demand. Right now, we have invested a lot of resources towards our natural language processing and AI, and currently close to 45% of our answers are answered via bot with a accuracy around 80 to 85%. Just a quick snapshot on how Maya works. As I've just said, users are asking a question. Here, I just want to highlight a little bit about the demographics of Maya users, which is 60-40 in terms of female, male. We feel great in the sense that even male are asking questions about the women in their lives or about something personal and private about them. So they ask a question through the app or the web. As I said, our AI analyzes the type of the question and assigns it to the experts or bots for humans, the critical answers, they refer the critical answers, and for bot, they answer the more frequently asked questions. Our AI is actually, the AI answers, and of course the human answers are vetted by human doctors. So that level of quality and assurance and accuracy is that much higher than any standalone tech assertion that is needed. And then the answer is published in the stream. And in the end-to-end process, everything is encrypted, so no one knows who the question is coming from. I just want to highlight just a few questions. We have picked the ones that have come in English. So the majority, the majority of the questions that come are in Bangla, Banglish, and English. We only have about 10 or 12% of our queries come in English, but the rest are in Banglish and Bangla. So the ones we got in English, one of the examples are, hi, I'm 17 years old. I'm a boy, but for me, it's nice to be a girl. I love to wear clothes, take makeup like girls. I can't accept my body. Only for these reasons, I cut my body with blade few times. Why am I like this? So these are just one of the few examples that we get on a regular basis. You can see other examples there, and happy to share more if anyone is interested, but it just shows how closed or close these people are, in the sense that when they have questions like this, they cannot go outside, let alone talking to an expert, maybe in many cases, not even to their friends and family. Like I said, men are asking questions on how to come out of drug and substance abuse, feeling very suicidal because they're like the only earner in the family. And of course, on the women's side, we have the whole cycle of, we also get a lot of physical health questions. So from when women are getting pregnant and then they face the postpartum depression, it's a clear cycle. And then they ask all those questions. Even them, they feel very cringed in terms of asking a very personal question about their physical body. So for example, while breastfeeding, all the way to having issues when they're trying to have, sexual relationship with their husband, and so on and so forth. The data that we're seeing on a regular basis, it's a treasure trove of data and trust that we're sitting on. Up until just a few months ago, the growth of Maya has been pretty much organic, and that just shows like the trust that Maya has been able to build. This chart just gives an example of, the type of categories of questions we are receiving. Obviously, as I've said, we get a whole lot of questions on sexual reproductive health, basic sex education, contraception, family planning. And again, a lot of it is to do with the three main barriers I want to highlight. One, first and foremost for Maya, is the social stigma and the taboo around it. The second was the geographical barrier. On an average, around Bangladesh, people has to walk 7 miles to go see a nurse, let alone a doctor. And then the financial burden. 90% of Bangladesh's healthcare is private. The average wage does not compel to go and visit doctors on a regular basis. It costs them a leg and an arm to go see a doctor. So we feel Maya cuts through those barriers by having access to an app which has access to experts, licensed experts 24/7. So that cuts through these barriers and helps them to ask the question that even if they had access, they wouldn't be able to otherwise ask, just because they just don't feel comfortable asking those questions. Our questions on mental health has increased 300% over the course of 2019. Some of the examples are here, where it says, we are getting a lot of questions on depression, tension, anxiety, frustration, marital relationship, romantic relationship is something that's increasing as well, social issues. These are just few of the categories. We can slice them down even more, and it's really interesting to see these kind of questions coming in, particularly around when we're analyzing the data, like why are they asking this question, which part of Bangladesh they're asking from, at what time of the night or in the day they're asking these questions. So we are more and more, we are working with data scientists and trying to figure out how these questions can be then, or these data can be made use of later on. Just going through the quickly channels of Maya, we have the app service, web, Obviously, we have kiosks, which we are just kind of like a tower which we place in garments factories. We're closely working with garments factories right now. And the back end of our service is called Florence, which deals with all the consultations, right around as I just said, 4,000 to 5,000 consultations every day. Transform is, just wanted to highlight this because we feel it's a huge potential and opportunity for us, that we've got some funding from DFID and Unilever's program, but so far Maya has been working online to reach the users, and however our offline presence wasn't as strong, just so that people is aware of Maya on a more broader scale. So I think the project that we are working on with Transfer Unilever London it will help establish like 10 wellbeing centers in peri-urban areas. We will hire a female facilitator to kind of have the offline online cycle going on between the users and Maya, and then of course hold free health camp and stuff. So we are just lucky that we are able to do this in the offline space, which we haven't been able to do so far, and trying to reach more users outside of the urban area in Bangladesh. What is our goal in terms of 2020? We want to reach, obviously, since we're seeing a lot more traction on mental health, our whole strategy towards mental health, including experts and their guidance, revisiting our tags category, really to strengthen our mental health strategy. We have an internal target of increasing our mental health capacity and questions. We have onboarded a lot more experts, not just in Bangladesh, but globally. We want to reach about 10 million monthly active users, a couple of million outside of Bangladesh. We've already started working on our market expansion plans for UAE, Saudi Arabia, and Pakistan. And right now we are past the stage of, or kind of still like in the stage of testing our Arabic and Urdu bot, which is going to help exactly how we've launched in Bangladesh, starting with technology, starting with bots, because obviously in places where supply is less than demand, you will need technology to scale. And then in terms of other business areas, we are looking to really work with partners in business. So as Babylon was just saying, that part of our revenue model relies on having business having a partnership with businesses, such as starting with Garments Factory for Bangladesh, then corporates and also insurers. We have a direct B2C consumer offering, so whereby anyone can buy a subscription where they get digital prescription. And do want to highlight that digital prescription is something that is getting more and more. And again, at this day and age where we are suffering and in a lockdown position, in a lockdown for the COVID-19, this is becoming more and more essential. So digital prescription helps people to cut through the queue. So often they have to wait around 3 to 4 hours to get to a doctor. So that cuts through. And through the premium subscription, which users have to pay, they get digital, they get an inbound call, they get digital prescription. So that is proving to be very, very gaining a lot of traction. The others are obviously.
I'm sorry,
Yeah.
we're getting close to the end of time.
Okay.
So yeah, if you want to wrap up this slide, we can go to 1 or 2 questions.
Yeah, I mean, I can quickly go through the mental health state, and it's there as well. Like 16% of adults and 18% of children are affected by mental health. So that's approximately about 6 million depressive disorders. And then, as I said, we are trying to expand a lot more of our mental health efforts. And our plans for opportunities outside of Bangladesh we are focusing on Saudi Arabia, Pakistan in 2020. And we feel that, the population and the expat population around Pakistan and Saudi Arabia, and the similar culture in Pakistan is our market research shows it's going to help us to gain traction in those areas. So yeah, we're just really excited to be expanding to these regions and of course grow our user base in Bangladesh. Thank you.
Great. Thank you, Ivy. Unfortunately, we don't have a whole lot of time for questions, and a number of them here online that maybe we'll send to you. maybe we can ask sort of, one is sort of what, how do you get the word out? You said it's been mostly organic. Have you, I guess,
Yeah.
what is your marketing strategy?
Yeah, so initially, one of our initial investors has been BRAC, which is one of the largest NGOs, and through them we've done a lot of community service. So BRAC reaches about 2 million women on any given day or any given time. So we were really consciously making strategic partnerships with their groups, so their gender team, their mental health team, their pediatric ward, and all of those. So through them, we were able to spread the word. And then we've also actively worked with universities because we've seen like the majority of our users are really young, 18 to 22, and they're very tech savvy and students. So we've tried to spread the word through the BRAC community and universities first.
Outstanding. Well, thank you, Ivy. Unfortunately, that's all the time we have for right now. Like I said, maybe we can send those questions along and post your answers later on. But I'd like to move on to our next mental health innovator, which is IRD Global. Anita Pasha, the country director for Pakistan, will be talking to us about IRD. Anita? Are you with us, Anita? Okay, maybe we can, Ivy, if you're still with us, we can take one more question while we locate Anita.
Yeah, I'm here.
Oh, I'm sorry.
I'm here. This is Ivy.
Yes, Ivy. Yeah, well, we can. We're still waiting on the next guest, and maybe. Looks like she's been able to join us. So, Anita, can you hear us?
Yes, I can.
Great. Well, welcome.
Just give me a second. It's not allowing me to. Okay, there we go. So, give me a second.
Great.
Hi, everyone.
Please go ahead.
Great, thank you. Hello, everyone. I'm Anita Pasha. I'm the country director of IRD Pakistan. I'm going to be talking about IRD's mental health program, but before that, I just want to give a little update on what IRD is. So essentially, interactive research and development, we're a research and public health service delivery organization based out of Pakistan. We started out of Pakistan, and the ultimate goal is to improve the lives of vulnerable communities through innovative healthcare programs. I'm not going to go through this timeline, but this is essentially to show that IRD itself was founded in 2004. And in the last 16 years, we have grown out of Pakistan into a global organization with country offices in 8 other countries from South Africa, East Africa, as well as East Asia. This is just another visual to show the disease areas in which we work. So IRD started out as a TB program in 2004. Currently, we have a very large maternal and child health portfolio. We have programs in infectious diseases, communicable, non-communicable diseases, as well as global surgery. So specifically, I'm going to talk about the mental health program called Pursukoon Zindagi, which means peaceful life. It's a program that I started in 2014. Just to give you a little bit of context, it comes as no surprise that in the mental health state in Pakistan is quite dire. We know that the prevalence of depressive disorders in men and women is very high, as you can see the numbers on the screen. But we also know that there are hardly any, or there aren't enough healthcare providers to meet the need for healthcare provision, mental health specifically. So essentially, Pursukoon Zindagi provides mental health services through an integrated lay counseling model and by leveraging mHealth technology. I will go into the details of exactly what we do in a minute, but essentially we have a community-based arm as well as a facility-based arm. And we try to make sure that we close the loop on healthcare delivery. The program has three basic components. So we do demand generation, which is awareness raising, community outreach in low-income communities in Karachi. We have a capacity building component where we train community health workers to be lay counselors. And then of course the service delivery arm. So I'm going to talk about the challenges and what our program is doing to address them, and how it all fits together. So as I said, we know there's a lack of awareness about mental health in Pakistan. So what we do is we get groups of 10 to 15 men, women in low-income communities. We sit down and we say, let's just talk. Let's talk about what's going on. Let's talk about what's bothering you guys. And it's sort of a guided, facilitated conversation towards mental health. And through these conversations, we talk about what mental health is, what signs and symptoms look like, what to do if you feel like there's something that you are feeling, coping strategies, what to do if you see somebody in your family or somebody around you who may be struggling with mental health issues, and then when and where to refer people if it's something that needs additional care. So in the last 2 years alone, we have engaged over 20,000 people in these small guided group dialogue. The second challenge we are trying to address is that, as I said, we know there aren't enough mental health professionals. So we have developed an 8-day basic counseling training manual, which we have used to train over 180 counselors so far. So again, from these communities in which we work, we take people, we train them to be basic counselors, and they go back into their communities to be able to provide frontline therapy for depression and anxiety in their own communities. We also know that if we, you give the awareness and at the same time you provide the services, there still tends to be a low uptake of mental health services. So people don't come back for their third, fourth, fifth sessions. And so in order to address this challenge, what we've done is integrated our mental health program into primary care and routine primary care services, as well as public health programs that we have for chronic illnesses, such as TB, diabetes, HIV. So when patients come back for the regular visit to meet their healthcare provider to pick up the medicines for their follow-up visits, we make sure that a counselor is there to provide them their next session, or even the program teams of these primary care facilities, the staff is trained in basic counseling to be able to address the mental health as well. As we've talked about, the presenters before have talked about digital health. And I think for us it's very important to make sure that we're able to track the processes and the data in the field. So what we've done is developed an app. We've developed this app in-house, which the counselors use to register, screen, enroll clients. But at the same time, this is where they maintain follow-up data on their clients. So which visit they're on, what happened in the last visit, when is the next one scheduled. And it allows us to have this entire program be completely paper-free, but at the same time, it allows the program team to look at the data in real time and to keep an eye on what is happening where, in which areas with each counselor, for example. Finally, one of our biggest consistent challenges that we have constantly been faced with has been the lack of adequate space for counseling. So, in the communities in which we work, a lot of, these are slum areas. So in a lot of places, the joint family systems are in place. And so there isn't that private confidential space for people to have a conversation. Similarly, when we work in hospitals or facilities, there's waiting areas that have hundreds of thousands of people, and our counselors are often sitting in a corner and whispering to their client because we just don't have that space for counseling. So to address this, we recently launched our Pursukoon Zindagi Wellness Centers, which is essentially these shipping containers which we have taken and refurbished and renovated to be these wellness centers. And these are some of the pictures of what it looks like from the inside. And the idea is that people can just walk in to just de-stress, speak to somebody if they want to. We can have counseling sessions here. The space opens up and becomes a space if we need to have support groups for, let's say, HIV patients, TB patients, or just the awareness session groups that we're doing. And the vision for this is that some of these would be stationary in some of the facilities where there are very high volumes, but also we would have some mobile centers that would just drive through communities and stop at a particular place and just gather people around to talk about mental health or to just interact and engage with people. What this has also allowed us to do at a conceptual level is shift the paradigm a little bit from illness to wellness. So yes, we're talking about depression, anxiety, and we're talking about the screening and the, providing services. But here we also want to talk about positive mental health and use this space to, for example, have sessions on mindfulness or yoga, eventually get kids involved on some play therapy, art therapy. And so this is an initiative of ours that we're very excited about, that in some ways can bring it all together. So I'm going to bring you back here to this in a minute. Everything I've talked about falls into this framework. Some of this happens in the community, some of it is happening in a facility. The way we function is that we engage with primary care facilities in low-income communities, and in the catchment area around it is where we will do some of the awareness raising or some of the positive mental health work, but refer back to our counselor who's sitting at the primary care facilities in order to close the loop. So for the last couple of years, just some of the achievements we've had, we've trained over 180 counselors who are currently deployed in the city. We have mental health services integrated at 20 facilities. We've screened over 150,000 people, of which from the 10,000 people presenting with symptoms, we have been able to enroll 9,000 people for individual one-on-one therapy. Finally, looking ahead, what we want to do is, of course, strengthen the program, because there's always room to strengthen, but also scale it up. This year, we have scaled this program with 3 of the largest primary care providers in Karachi. And we've implemented this model. And what we want to do, ideally, would be to scale this up nationally through partnerships, but also see if there are ways in which we can replicate this model in other countries across the IRD global network or even otherwise. So thank you.
Great. Thank you, Anita. We have a few questions from the audience. Please, other folks, if you have questions for Anita, please type them in using the Q&A icon at the bottom of your screen. A question from Deepak is, how do you identify the cases in the community?
So we use a screening tool. We were using the SRQ-10, which is a 10-item questionnaire, and we have recently shifted over to using the PHQ-9. And so that's our initial screening. This is followed by a locally developed 25-item anxiety and depression scale, which we use to do the second line of screening.
How are you assuring the quality of the counselors?
So what we do is, so we have the 8-day training. In addition to that, each counselor is supervised by a clinical psychologist. The clinical psychologist meets with each counselor once a week for one-on-one supervision sessions. In addition, she will meet with her group of counselors every 2 weeks to do refresher trainings, because obviously it's a lot to soak in 8 days. So every 2 weeks we have a refresher training, because a lot of what these counselors are learning, they're learning on the field as they go. And so this is an opportunity. They may come back and they say, well, this is something that's bothering us, and the clinical psychologist will have a refresher training on that. In addition, we used to do this earlier when we first started in the first 2 years. We would record all of the sessions that the counselors would do in the field, obviously with consent. And then we had a psychologist who would just listen to that and then give feedback to each counselor based on how they were performing. So, she may say things like, at some point you should have probed a little bit more, or at some point, this was a problem area, so when you meet them next week, you can go back. The clinical psychologists, we have 6 on our team at the moment, are working very closely with each counselor. We do spot checks in the field where she will sit in on the counseling sessions that are happening. As our program team does the same to ensure that the quality maintains throughout.
Outstanding. I think we're at the end of our time, but there's 1 or 2 other questions. Maybe we can email those to you. Thank you so much for joining us, Anita. And maybe you can stick around and answer questions on the chat as we go forward. So our 6 mental health, 6 Innovator, and our 3rd mental health company is WISA. Presenting for WISA is Joe Agarwal, the co-founder. Joe, are you with us?
Yes. Hi, can you hear me okay?
Yep, we can hear you fine.
Awesome. I'm just seeing, a trend here. The first few presentations were of sort of organizations from developed countries doing health work in South Asia, and the last few and ours are South Asian organizations that are expanding across the world. So I continue the trend of an Indian organization that's trying to address global mental health. What I started this whole journey, I'm not a psychologist or a healthcare professional. I started this journey from my own personal experience with depression. I'm a technologist, and which left me with just one question, saying me and a lot of my friends were using AI to do marketing and sell stuff. And I said, can we actually sell mental health support using AI? And WISA wasn't the first output of it. It was almost an accidental discovery that this works. What we started out by doing, like most tech folk, is saying, can we use the sensor data from a phone to detect if a person is depressed? And we actually ran trials in semi-rural India and found that actually, yes, you can actually take some of the a smartphone, but a not very expensive smartphone, and you can actually take data from it, which is not very personal. So the gyroscope, accelerometer, the anonymized locations, and so on. And you could, to a 85 to 90% accuracy, predict whether a person is, or at least classify if a person is depressed or not. And we're quite thrilled with this. And 3 months later, we went back to the primary care physician that we had done this trial with, who was following up with these patients. And we said, what happened? Did we help anybody? And they said, well, one person took therapy. We had detected 30 people in that small trial out of our patient pool of 100 people. And one person had taken therapy. Now, to do this, we had actually created a chatbot. A small chatbot in which we had put this technology that would capture sensor data. It was almost like a Trojan horse. And the same people who were not willing to see a therapist for various reasons, access, cost, stigma, were more than happy to talk to this chatbot. At that time, it didn't have AI, it just had multiple choice. It was in 3 languages. And 3 months on, they were all feeling better. So that sort of woke us up to say, is detection even that much of an issue? Can we actually scale mental health by giving people something that they're willing to talk to? And we sort of flipped it from saying, how can we improve healthcare, to saying, how can we bring user agency back into mental health? And it was a big realization, both from my own experience with mental health, and I think this was a big wake-up experience, to say at the end of it, the stigma, the lack of access, the biggest issue is that people feel like admitting this issue or working on it will take away their agency. And we have to therefore find a way in which we can massively scale reach and engagement and give people a sense of agency over their own well-being. And not in a way where we have to have a doctor prescribe it and so on. And we have to still do it efficiently without adding millions of therapists or coaches or counselors, because as you've seen in the previous 2 presentations, and likewise in India, we just don't have any professionals. And that's not just true for India. That's also true for the UK. That's also true for the US. In the UK, the waiting lists, in Canada, in a lot of these public health countries, the waiting list for mental health run up to a year. So you can go in with suicidal ideation, attempted suicide, and not see a psychologist for 14 months. During that time, of course, people get worse. Now, how do you put something which has got engagement, which does it efficiently, doesn't need a lot of therapists, but still achieve the kind of efficacy that a clinical intervention should achieve, that it actually helps and has all the rigor of it? And that's sort of what we started out realizing, that we had the seed of it in this simple chatbot that we'd built. And this was 2017, early 2017. And 6 months after actually working on this and building this, we got a mail from this 13-year-old girl somewhere halfway across the world saying that this was the only thing helping her hold on to life. She was depressed and she had tried to commit suicide. And that's when we realized that we were on to something. We really needed to make this clinically effective, proven, rigorous, and this was a hypothesis that bared for us to explore more. And as we explored it, this is what we found. Remember, what we're trying to do is try to scale mental health in a way that bypasses stigma, in a way that bypasses lack of resources. These are the two big issues that even other presenters have talked to you about. And what we found, and now there's lots of other published research that supports this, but we found directly by experience, is that people have no stigma in talking to an AI chatbot about their mental health issues. People actually want to be heard. Now, why AI and what does AI do here? It's a very interesting thing. There is absolutely no, if you think of an AI chatbot, you'd often think of something that's self-generating ideas or coming up with things to say based on what people are saying to it. That is not what Wiser does. I'll talk to you a little more in a bit about how Wiser works, but AI, so that it does something called NLU, natural language understanding. It allows people, rather than pushing buttons and selecting columns from worksheets, it allows people to just vent and talk about what's going on in their mind. There in itself, in that first action of taking all the emotions, feeling in the first 15 seconds, what a therapist takes 2 sessions to get to, a sense of safe space where they can actually open up and talk about everything that they want to, feeling that safe space, articulating it, journaling it to a bot, that's the beginning of therapy already. Often we have found, and I'll talk about numbers in a bit, in this free AI chatbot, we do not charge for this AI guided self-help. And in this free support, often in a matter of 10 minutes, people have discussed their issue, found what the fallacy in their thinking was, reframed it into a positive thought. So they've done a cognitive restructuring exercise from CBT, very much as the worksheet would have asked them to do. And they walked away saying they're feeling a lot better. And this is one chatbot that can achieve this at no cost, hardly any incremental cost per person. Now, it's true that not everybody will be able to manage their own emotions. There are people who are dealing with issues which they are in a position to have self-help. There are also people who absolutely need psychiatric support or need in-person support from a psychologist. Now, what the AI-guided self-help can also do is provide an escalation of care pathway. So it also says, for instance, for somebody who's talking about suicidal behavior, at-risk behavior, somebody who's mentioned panic disorder, abuse, a whole bunch of different conditions, but also highly distressed by the same condition over time and unable to help themselves, it escalates them to say, you should probably talk to an in-person support, but if you can't, here's text-based therapy. Now, text-based therapy is not quite as large scale as a mental health professional, but it has 2 other things going for it when you think about it from a user's perspective. One, it can still be anonymous. You still don't have to tell anybody who you are. And 2, it's something that you can do even if you're sitting in the middle of a room. Now, imagine a teenager at home, you're sort of sitting with your friends, you're sitting with your family, and you're texting. That's a very normal scenario for most people. If you're texting your therapist, they don't need to know. So nobody else really needs to know that you're texting anybody except a friend or you're on Snapchat or whatever. And that kind of a safe space and safe environment has been critical for people. There've been some people who are so unwilling to be seen as being weak that they only text when they know that the therapist is not online, and others who really have good live sessions. But we can, through this, bring down the cost of providing this therapeutic support without compromising impact. Having people work through and having great follow through, people working on their issues for years on end if required, but many of them at least going through the 3 months of support and sticking to their regimen. We can do that where one therapist can support 200 people. And also this therapist can do a triage in just one text therapy session or two and say that this person actually needs to go up to a face-to-face counselor or be referred to a doctor or a psychiatrist. So that's sort of the care pathway that we have arrived at. And in each of these, there's lots that we have innovated. But I'll just go to what we have achieved doing this. So we launched in early 2017, late 2016. It's been 3 years.
I was just saying that we're at time, so yeah, if you could wrap up quickly, that'd be great.
Yes, of course. So far, a lot of people have used us, as you can see, 1.7 million users, but we've had 1 million breakthroughs every year. So 1 million cognitive restructurings annually for free. And that's the kind of scale that we've achieved. And I just want to add one more slide and then I'll wrap up, which is that this has to work if it is actually clinically safe and it has had its effectiveness proven. So we're rated by ORCA, which is NHS's rating agency for health apps, as the highest ever on any health app on clinical safety. We're rated 100%. And it is the app that NHS promotes to all of its patients who are pre-diagnosis or don't meet criteria. But it also, we've published effectiveness of a chatbot to say that it actually has help in depression. I'm just going to, these are some of the other things that we can do in terms of trying to make NLP AI health ready. And I think one thing that we are able to do is make it voice ready, make it free text ready, which means that, and localization ready, which means that if you had a need where you had to provide this kind of support over voice on a phone or over SMS or USSD in a local language in a developing country, we're ready for that. We're here to look for partners that we can do that with. Thank you.
Great. Thank you so much. So a few questions from the audience. I guess, how do you maintain the ethics of privacy in these healthcare-based apps?
That was, I think, our first issue. So when we started out, we said this is user agency and whatever the user agency wants has to happen. So the first thing is there's absolutely no personally identifiable data collected by us, let alone, you know, for us to keep it safe, if somebody tomorrow hacks us. So everything on this app, including when a person accidentally gives us personally identifiable data, we automatically redact it before storing it. And from another point of view, you also have to be careful that, for instance, if this app is something people are beginning to depend on, then if it goes down and they then struggle, then we have to make sure that we've met all of the standards of clinical safety, both if a person is talking about a suicidal issue or if a person is just dependent on it and the app is going down and they should not be triggered in any way. And that's what we do in terms of our standards of DCBO 129 and clinical safety, etc.
Great. I think we have time for one more question. So I guess I'd like to ask a question that I posed to Claire. Is sort of, you know, you've got an innovative network here as your audience. How, you know, what is, you know, I guess, how can we help in with your expansion strategy?
So right now we have two types of strategies. One is to work with pharma and healthcare in developed countries with insurance providers, etc. And that's going quite well. But there is something that we created this for, which is to create global impact. And we really need partners. So for instance, partnering with someone like Maya to be able to provide our power in addition to their ability to get users would be amazing. To partner with organizations in different countries who are working in developing economies, who have figured out the grant ecosystem, have figured out the last mile, have figured out user you know, how to support people on an ongoing basis. We have technology that we'd love to partner with them on and make sure this really scales.
Well, thank you so much for your time and for presenting WISA. Fortunately, we're out of time. So we'll send those questions on to you by text, and maybe you can answer those. So our last innovator for this morning is Paul Musk. And presenting for Homusk is Nawal Roy, the Chief Executive Officer. Nawal, are you on the line?
Yes, Jed, I'm here.
Great. Well, good morning. Please take
Good
it away.
morning. So can I request you to, run the slide for me?
Go ahead.
Yeah.
Yep.
So first of all, I mean, it's a pleasure to be part of IiH, Innovator cohort, and more impressive to see that, such an amazing group of entrepreneurs solving this problem for, multiple ends, which is very, very impressive. I'm also quite impressed that there are more female than males, and I seem to be the minority in this cohort, which is a good place to be. If I can go to slide number 2, this statement somehow sums up the whole landscape of mental health globally. That when it comes to mental health, every country is a developing country. What it really means is 2 or 3 main things. One is mental health in general in the very earliest stage of fully being adopted and fully being understood, from biomarkers to intervention to counseling to a scale solution to medication and what have you. And the approach that we have taken out here is a very narrow approach of very clinically sort of obsessed, and evidence-driven solutions that can be built. And hence, the key problem that we are trying to solve are twofold. Number one, that there is a very high degree of trial and error that goes on in the treatment of mental health. And number two, if you take the reverse image of the same problem, is what is the right medication for the right patient? And looking at that problem, we started almost around 5 years back. And if I can go to the next slide, essentially, our goal is to build one of the largest real-world evidence platform where the data is being captured from the real world. And when we talk about real world, that is either the domain of the electronic medical record system or the digital solutions like, the Visa or Maya, what have you. All of these have been built, and how do we aggregate the data from all of these sources, which can lead to definitions of digital phenotyping and things of solutions of that nature. But the hardest task is to convert the data that is coming from there into objective evidence, which can be used for, research publications, scientific publications, or clinical purposes. In summary, we are building 3 layers of sort of key skills. One is around the electronic medical record system and building the data pool itself. Number 2 is digital solutions, which enhances the digital phenotyping or the capturing or the access of the data itself. But the number 3 is more around evidence generation engine, which becomes the sort of the key technology that feeds into from drug development to clinical trial to what have you. As a company, we are 5 years old. We are in 50 or around 55 people now, headquartered in Singapore, but also a significant presence in US, both in New York and North Carolina, but also based in UK and China. And if I were to look at 2 major markets that we are really focusing, is US and China are the 2 major markets we are working in. If I can go to the next slide, this gives you a view of, what is the current state right now. And, it's a very sort of narrow summary of what we are building. The massive amount of the real world data is coming from the electronic health record system. And as of now, we are deeply focused on a specialist electronic health record system and not the epics of the world. But the electronic health record system that is only focused on mental health. And the number 2 is digital therapeutics, the digital solutions, which are app-based, and mobile-based solutions, and how do we extract data from that. The middle part is the evidence generation engine, and that is where it's a proprietary sort of huge architecture of technology, data collection, cleaning, making sure the data points are, well validated, and then building solutions where, the objective evidence becomes the source of key input for a lot of this. And we have a narrow view of the solution right now for, for the clinicians, essentially for the doctors. And number 2 is we are enhancing that by reducing, trial and error, but also building clinical decision support systems, which can be used to scale and things of that nature. So if you look at the integrated care model, in that space, as of now, we are building a layer of digital solutions on top of electronic health record system, which can lead to capturing of better data in between the two trips of a patient coming to the hospital. And essentially, so the integration of the data that is coming from the EHR plus from digital solutions and leading to objective evidence is the key solutions that we are building here. The second part of that problem is essentially how do we really solve the problem of better patient selection, but more around how do we find the right patient for the right medicine, and hence we are building layers and layers of solutions around that, by which we can model a particular type of patient profile or a particular type of literally building solutions for market access problems, RWE problems, HER problems, and what have you. So these two are the main sectors that we are working. I think there is a real appetite to go and really figure out a standard of care and how to really solve that problem for the payer market, and more around how do we really take it to the scale level for the governments and what have you. But in the market for payers as well as for the government, we are still in the very early stages. If I could take you to the next slide. Oh, sorry, I think I went too far. So if I can go one more down, Jed. So this is the pharma slide for the for the validation. The next slide gives you a way of understanding where the overall market is going. So Jed, next one. Yeah. So this gives you the overall sense of where the market is, and this is broadly a US market focused, but overall distribution of the behavioral health market is spread across from the government to the commercial market to the providers and the pharma company, and it shows the layer of the expansion and literally the focus on this from multiple angles. Summing it up, I mean, I want to keep it short and sweet given the time constraint for the next session. In the last 5 years, we have certainly come a long way in terms of building a solid partnership, and some of the leading ones is being part of J&J, J-Labs, both in New York as well as in Shanghai, but also recognized as a technology pioneer company by the World Economic Forum. And then if we could go to, here is a sample of some of the major sort of our partners, both in the academic space and the science space, which is all across from US to to Europe as well as in Asia. We are still expanding very deeply into sort of the Asian market, especially in China. And pharma partners are Janssen, Johnson & Johnson, Amgen, Pfizer, Merck, Bayer, and the payer and the employers market is all around the AIA and the Ministry of Health in Singapore. I'll stop there, but I think if I could reverse back to the reference of that every country is a developing country when it comes to mental health, I think it requires a layer of sort of the spirit of climbing Mount Everest, and this picture is symbolic of the last slide. If I could take you, is a symbolic of what we are trying to do. Is a sort of bloody hard task, but it's a great privilege to be part of this cohort, and we'd love to extend any support that we can handle or any support that we can get from the cohort partners as well as others. And I'll stop there, Jed.
All right, thank you, Nawal. Yeah, please, audience, submit any questions that you have about Homeless into the Q&A section. So Nawal, I guess I'll ask the same question I've asked several of our other innovators is, as part of the Innovator network and having access to a broad range of potential partners out there, I guess how can we help you grow and expand and meet your expansion strategy?
Yeah. So I think one of the key challenges is literally our access to the government partnership all across the world. And one of the key challenges is what we are building, the resources that is required, and especially around the research fundings and the grants that is available out there. As of now, we have a very narrow view of that world, and we certainly have very limited knowledge of how to approach them and the process that it takes to get there. or more around, is it even worth it, because the process itself can be 3 years long, and whereas a company like us don't have the luxury of really planning for 3 years. And so any guidance on that front as to, hey, work with Wellcome Trust, don't work with this and that kind of knowledge, or work with World Economic Forum, and here are the guidance to go about it, and who are the key players in that space. Those are very, very valid knowledge for us, and which we can love to leverage using the IiH network.
Great, thank you. And one other question. So you outlined how this real world evidence model can help in the development of new therapeutics. How does this model impact sort of prescription patterns of drugs currently on the market, and how might that impact a doctor working in a low resource setting?
Yes. So number one is certainly there is a high degree of comparative effectiveness in a very objective way that you can do from one drug versus the other. So which drug is the right drug for what kind of patient? That is a classic domain of CER studies, and we have done lots of them, and we have multiple publications around it on our website. Number two, I think most clinicians, when they are working right now, they are essentially dependent on their own expert system, on the knowledge of the prior knowledge of the patient that they have seen. Here is an aggregated view of all the other patients who are on the platform of the EHR, and we are continuously building one of the largest EHR player that is out there in the behavioral health market. And there is an aggregated approach by which you can really understand that, okay, what has happened to a similar patient which the other doctors have seen, and what is the probability of which drug has worked. And a statistical distribution of that probability gives a sort of qualified objective data to a particular clinicians, and they can leverage that to really, so it's not necessarily saying that, okay, you have to have this prescription, but here is your objective way of looking at what, what has worked on the similar patients, and leverage that technology.
Great, thank you. Any other questions from the audience? Please submit them. Tell me a little bit about your work in China. What is Almost doing there, and what's the objective of that?
Yes, so we have partnered with Janssen to build essentially a large digital mental health strategy for China. The key intent out there is, before 2015, mental health was sort of a taboo, a serious taboo in China. But if you look at China 2030 mental health plan, mental health is, or healthy China plan, mental health is front and center of that. Number two, I think that the problem of the ratio of the psychiatrist versus, the patients are, as large as anywhere else in the world. But at the same time, the penetration of digital tools and the penetration of internet hospitals, which is an amazing word to, think about it, is also expanding faster than anywhere else. And our bet is that digital solutions in China will go faster than anywhere else, because there is a deep focus on that from the systematic point of view. And hence our goal is to, literally partner with these and literally build digital solutions which can work either as a companion solutions for a drug, or really expansion and a scale solution for digital therapeutics itself.
Well, thank you, Nawal, for presenting Hallmusk. Let's see, let me see if there's one. So here's a question. Given the stress and anxiety caused by COVID-19 in your two biggest markets, do you have any thoughts on using Hallmusk to assist there?
So I think we would be very, very welcome to assist anyone, when it comes to essentially either a market awareness of the knowledge itself, or they want to use our capabilities in the data science. There is a high degree of, sort of really differentiating between what really matters and what doesn't matter. The deep data science technology can be used in that space. And so any partner, we would be very, very keen to help.
Well, great. Well, thank you. Thank you very much. I think that we're at the end of time here. We're going to take a short break until 11, at which time we'll be presenting the panel addressing the global health challenge. Hope you'll stick around and join us for that. And thank you again, Nawal, and thank you to all our innovators for presenting this morning.
Thank you very much, and it's our pleasure.
COVID-19 briefing is at 2 o'clock, which is the brand new call.
Okay, well, I'll probably do the COVID thing.
All right, welcome back everyone. We're going to move to our next session now, which is addressing the mental health challenge. We go to our next slide. It's my great pleasure to hand over the moderation of this session to Peter Varnum, who leads global mental health programming at the World Economic Forum. Our other esteemed panelists that will be joining this conversation include, to my right, your left, Dr. Victor Zhao, who's the president of the National Academy of Medicine and also serves as the chair of the Innovations in Healthcare Board of Directors. We have Garen Staglin, who's the chair of the board of One Mind. Nicole Bardikoff, who is the program director for global mental health at Grand Challenges Canada, also joining us. And we'll have this conversation. Husseini Munji, who's a global therapeutics area head for neurosciences at Johnson & Johnson and Janssen, will be joining at some point over the course of the conversation. He's been called away to an urgent meeting internally. And unfortunately, Dr. Murali Doraiswamy here at Duke won't be able to join us this morning due to a last-minute schedule change that's urgent here at Duke as well. So with that, let me turn it over to Peter and welcome all of our panelists for this conversation.
Excellent. Thanks, Krishna. Can you guys hear me okay?
Yep.
Perfect. I see, Krishna, you're exiting the picture. I was going to give you and I'm just pushing him out. I was going to give you a little bit of a hard time because my college basketball team, Kansas University, was looking really good, and I saw the KU initials from you on your screen, and I know we have a nice rivalry going. Anyway, it's a pleasure to be here with all of the esteemed guests, and thank you everyone for being here. Just again, so everyone is aware, we have Victor Zhao, Garen Staglin, and Nicole Bardikoff here with us. We're going to go through this session on the global mental health challenge and how technology and innovation can address it for the next hour. I wanted to give you just a sense of how the discussion will go for the next hour before we jump into those remarks in the conversation. So we'll let each panelist have a couple of minutes, 3 or 4 minutes for introductory remarks, and then we'll launch into a discussion after that for the majority of the session. And then of course we'll have a bit of Q&A from the audience, as we've seen for most of this morning before we conclude. Before I turn it over to you, Victor, I want to just ensure that everyone knows the reason behind our having this session. So obviously a lot of shifts, and again, thank you to Judd and Krishna and the team at Duke for shifting on the fly. But the purpose of the session today is really to discuss in greater detail the potential benefits of technology and mental health, including some of the obstacles and the opportunities that we're facing. And I think it's apropos that we heard this morning from all of the innovators already, and now we'll get to hear a little bit more on the high level thoughts of people who are working globally. So with that, Victor, I turn to you, and maybe if you could just give a sense of the challenge and the opportunity globally, other comments that you might want to make to start off. Over to you.
Thank you. Thank you, Peter, and it's great to join this esteemed panel of experts to discuss a very important issue, which in fact you all know, which is brain health or mental health, but we think about broadly as brain health. I think that all of us recognize that this is a very important issue from the health viewpoint, but also from societal viewpoint. The burden of disease is huge, and the cost to the society is substantial. And I think everybody should care, because this impacts not only on health, but families, economy, security, you name it. And the numbers are only getting worse. So I'm going to say, tell you a little bit about the global numbers. First of all, mental health and substance-related conditions are a great contributor. Most important contributor to global disease burden, is the #1 cause of disability for adults globally. Approximately about 450 million people worldwide live with a mental illness. And if you look at who's impacted, I would say that 1 in 4 people will be affected by mental or neurological disorders. 90% of nearly 1 million people worldwide who die by suicide each year usually have a psychiatric condition. Also, it's a major cost of world economy. It costs about $3 trillion annually from both cost of care, but also the loss of productivity and so many other issues. And an estimated 12 billion working days are lost per year due to mental illness. So these are very big issues. If you look at the US, about 20% of Americans have a condition of mental health or substance use disorder, and 60% of those who have substance use disorder also have mental health condition. And certainly we can imagine the impact on disability and the risk factor for death by suicide, incarceration, and homelessness. So we also know that it's linked to chronic disease. In fact, mental disease and physical disease are closely linked to each other. So the question really is, why are we here and what can we do about this? First of all, I think that the world sees mental health generally as something they don't want to deal with as much. There's a big stigma. Everybody knows that. In different cultures, different countries, people don't want to talk about this, and certainly sometimes it's thought to be a weakness of your personality or others. Second, of course, is the amount of resources that's put into addressing the issue of brain health. To begin with, in low middle income countries, a very small percent of the GDP is allocated to health, maybe 1%. And of that, mental health gets really to the kind of bottom, if you will, of the ladder. Access is a real problem. 1/3 to 1/2 or more people with serious illness do not receive treatment in our country and everywhere else. And of course, we don't have enough workforce. If people think that you need to access specialists, there are not enough people who are specialists in behavioral health. So the question is, how do you actually enable people who know how to deal with these issues and provide them with access and the right workforce? Our healthcare is highly fragmented. And so even accessing care for mental health is a very difficult problem. And as I said, there's just not enough resources addressing this issue. Now, in 2015, the ratification of Sustainable Development Goals recognized the promotion of mental health, prevention of mental health and substance use disorders, and universal health coverage as targets of a health goal. And of course, we all believe in it. The question is, how do we achieve this? Now let's talk about some upside. There has been advances in technology and neuroscience and understanding better the brain, the development and genetic disease and the pathology. There are digital technology like telepsychiatry and others which have been helpful. So you're going to hear later on about this application of these advances, which I think are very important. But we know it's simply not enough. We know that billions of dollars spent in Alzheimer's, dementia, and that's not yielding much progress. But if you think about the majority of mental health, which is in the younger population, the youth, 70 or more percent actually in the youth from age 10 to 30. And of course, that's a very important population that needs looked at. So in summary, I would say that this is a global problem. This is a problem that we must deal with, in one word, to progress with a healthier and more productive society. But importantly, of course, we want to be sure that people who are afflicted with this problem are dealt with. But there's now more and more information on brain development and brain pathology. We should be able to actually take advantage of this and make a difference. What we're missing, quite frankly, is the investment. Now, so you're going to hear from my good friend and colleague, Garen Stacklin, about the initiative. I would just put it this way. I think we all recognize that investment is needed. A bold step going forward is absolutely needed. We can't really do things business as usual. Back in May 2018, the World Bank called together a meeting called Brain Bond, B-O-N-D, arguing that if we can find a new way of financing brain health, maybe we can really invest in the right things and move forward. So I look forward to hearing from Garen and from the others about this whole very important meeting panel of discussion, how we can really address this very important issue for all of us. Thank you.
Thanks, Victor. And you will certainly hear from Garen and others. One thing I forgot to mention, generally speaking, on this this type of arrangement, if you as panelists could just announce where you are and you know, physically just kind of get a sense of who's doing what. I could see Garen making some coffee and being sure that we're all here. I know that Victor.
Garen's got people in the background moving around. You know, I say, okay, at least his grandson is not behind him. Yeah, so I took the risk of leaving my home and came to this Duke Global Health, the Innovation Healthcare Center. With us are 4 individuals. I think we all are highly hygienic and we're 6 feet apart. I think we're okay. My biggest concern is, in fact, I'm going to be at the airport this afternoon and, well, okay, you know, I'm going to keep my distance.
Definitely keep your distance. I'm having a problem getting my aging parents to stay in these days as well. So I'm in Geneva, Switzerland. I have the option, I think, and I think my organization would want to have me have a different sort of virtual background, which looks like this, but I find, you know, a little bit too futuristic and I wanted to keep things a bit lighter. So I'm keeping my friends, the Beatles, in the background. Nicole, over to you in, well, I'll let you explain where you are and what you're up to here to talk in terms of what Grand Challenges Canada is doing in global mental health. Sorry, Nicole, so I'm sorry to interrupt. We're having a little bit of trouble hearing you.
Are you on mute?
Maybe if you could.
Is that better?
Yes.
Yeah, that's better.
Okay. Thank you. I was just saying thank you to you, Peter, for the introduction and for having me here. And I am in Toronto. I'm working from home. Grand Challenges Canada has given us that option. And I thought that I was fortunate enough to have the opportunity. So here I am. And Victor, that was such a great introduction to so many of the challenges and things that the field of global mental health is looking at and dealing with. And I'll give a little bit of a background on Grand Challenges Canada. So we are an organization that, for anyone who's unfamiliar, we fund and support innovation to save and improve lives in low and middle income countries. We have a number of what we call targeted challenges, and global mental health is one of them. It was a program that was actually initially launched in 2011, so it's been around for some time. Has funded over 95 different projects in over 30 countries. And we look at things and we fund programs at both what we call our seed and transition to scale level. And if anyone wants more information about how Grand Challenges Canada does things and what these different funding programs look like, I would say go to our website, and I won't spend more time on that today. What I will talk a bit about is how we've chosen to focus our global mental health program. Some of you may know that we haven't had new funding calls out from that program for some time, and I'm really excited to be able to say that that is changing. We are really relaunching and coming back into this space. We're going to have our first call for our new seed funding proposals out in May, and what we've decided to do is focus this on young people's mental health for so many of the reasons that Victor was talking about before. You know, knowing the time of onset for so many mental health challenges are during this phase of youth. And if we can intervene and provide support early, we can have a lot of impacts on so many different domains. So that's where we're looking to focus. And I would say that some of the things that we have found and what we'll be looking at and looking to support moving forward is innovations and programs that really are community driven and community based. You know, we know a number of the innovators previously, and Victor have spoken about a lot of the challenges about providing support in areas where there's not enough resources, where we don't have the same kind of perhaps mental health specialists that you might like to see to be able to provide that kind of care. So if we can find, we really look to support innovations that are driven by the community, that are well integrated in, and that take an innovative approach to how we can provide care and support, whether that be through task shifting, whether that be through leveraging technology to be able to get services to individuals in areas where they perhaps wouldn't be able to access these otherwise. And one of the other things that we really look for are innovations and programs that are, of course, able to be able to show that they are effective. And that's an area where we at Grand Challenges Canada are able to support some of that through what we call our learning platform. And we've done that in the past. But we really, and I know we'll talk about this a bit going forward, but being able to measure and track your impact is so important for being able to have to show why and how you can be sustainable, to be able to leverage more funding. I know that was something that came up in our panel previously as well. And then the other really key thing that I think is really important for us to be thinking about, and one of the things that Grand Challenges Canada looks for and will continue to look for, are things that really take a wraparound approach. So being able to provide programs and support and treatment is really, really necessary. And then what's also necessary is being able to then support that individual to go back into a context that has a better understanding of being able of what they need and what's happening in their lives, whether that be involving family, involving teachers, being able to integrate into systems that exist, and educating those individuals as well about mental health, and just really being able to work on mental health literacy in a really, thoughtful and intentional way to go hand in hand with being able to provide treatment and support. So with that, I will take a pause. And I really look forward to hearing from Garen and to the rest of the panel members as we move forward.
Great, thanks very much, Nicole. And I think that emphasis on cultural context, on community-based interventions, certainly we heard a lot, as you mentioned this morning, from how people are scaling innovations in places where there aren't enough specialists to meet the demand. And I would even argue that the solution anyway, even if there were that many doctors or specialists, would be that it needs to be more community-based care. So thank you so much for giving us a broad brush. And as you say, we'll come back with more discussion throughout the hour. Garen, I'm going to turn to you, and I'm going to remind you to just unmute yourself before you start talking. And I know that you've been working, as Victor mentioned, on the Healthy Brain Finance Initiative, and you have some slides to support that, but I'll give the floor to you to do your own introduction and how you want to use this next few minutes. Over to you.
Thank you so much, Peter, and it's my pleasure to be with all of you this morning. I'm here in Napa Valley. It's usually blue skies, but I think apropos of the global environment, it's kind of cloudy and raining here today, but we're not deterred. Our attitude is positive, and we're moving forward. Just to set the stage here a bit, and I guess someone's actually put my slides up to get started. So let me just say that my motivation in all this comes from the fact that this is very personal to me and to my family. My son Brandon had a psychotic break in 1990, and since that time we've been running towards this problem, pushing the envelope and accelerating research, trying to work in translational activities, and also working in society with programs in workplace as well as in media and culture. But I won't go into that today, but I would love to talk to all of you about the Healthy Brains Initiative, which Victor set the stage on, showing that global need and how significant this is. So we could go to the next slide. Am I advancing this, or are you guys doing it? There we go. So this is what we're trying to accomplish with this Healthy Brains Initiative. This is an unprecedented effort. Never in the history of global science has the global community in a field, in this particular case, neuroscience, come together to build a plan, to build a set of objectives, and to work together in a collaborative way to try to dramatically alter this economic burden. As you can see here, we're dealing with a $3 trillion global cost curve. And Peter, your organization has said that $3 trillion is going to go to $6 trillion by 2030. So as bad as COVID-19 is, it is nothing compared to the incident rate, the cost of disability, suicide, and everything else that goes with it. So we are crafting a series of financing initiatives. If we go to the next slide, you'll be able to see our approach here. So we've brought together this incredible group of people and collaborators with both World Health, World Economic Forum, World Bank, National Academy, and Bank of America has now joined us as our lead underwriter of this effort. And with advice by the National Institutes of Health, OECD, and others, I call your attention to this quote at the bottom from Tedros, talking about how important it has been for us to think creatively about new science, new funding, from bonds to direct investments. And we're very pleased for the strong endorsement and partnerships we have. On the other side of the slide, you can see the partners that we have already secured startup funding. The Wellcome Trust is not on the phone with us today, at least I don't think so, but Miranda Wolpert and Ed Whiting are clear and very active components of what the work we're doing, along with the other members that you see here. If I could go to the next slide. So our approach to this very significant effort has been structured around us forming 4 working groups of global leaders around the country, defining the research priorities, and apropos of what Nicole said and Victor said, we're starting with the crisis of youth between the ages of 11 and 24. This is where our research programs and our funding will begin. We're developing alternative finance structures. I'll show you a brief slide on that, of different ways for people to contribute. But think sovereign wealth funds, think direct investment, think high-level philanthropy, and other sources of general obligation bonds of states like the state of California to be joining in with us. We're developing a set of metrics that will help us measure how well we're doing, and led by Brad Herbert and Tim Evans, we're establishing governance structures that will emulate what has been with the Global Fund on AIDS and tuberculosis, as well as Gavi, to allow us to ensure that the best science on a competitively based basis is funded, and that we collaborate and share this information in an information commons around the globe. May I have the next slide, please? So this is just to give you a diagram to say that we're going to be looking at a variety of different sources of funding. Green bond funding is a term that if you're in the capital markets, you would understand. There's already precedent for this kind of impact-based financing that has been done in carbon and other footprints like that. And we're very fortunate to have the experts from Bank of America working with us to actually help structure and deliver these bonds. We also have Valerie Cohn and the Science Philanthropy Alliance and other philanthropy sources working with us on donor direct financing here. Victor made the point, but just to make it to you again, these illnesses are 4% of the GDP of most countries and going up. So this is a very good investment for them to proceed with us. And I can tell you that the subject of the return was documented for us by the $3 billion bonds that were issued by the state of California for stem cell initiatives that have now documented a return of almost 11 billion for the state of California, almost 4 to 1, and additional benefits up to 5 to 1 if we take all of the United States. So we believe that the people who participate will see direct benefit from this, and eventually the world, because it's our clear intention to disperse these new discoveries across the developing world and the developed world. And as your prior panelist said, when it comes to mental health, the whole world is a developing world. May I have the next slide, please? This will give you just a quick idea about how a 20-year financing instrument would actually show the benefits that would be generated. And if you look at the dotted line that's going up on the top, that is the net benefit using the California economic model. The below the line is the actual investments that are being made by a sovereign fund. Let's take Norway to be one of those, or Qatar or Singapore. And you can see that the net of the green versus the blue is such that the return is dramatically higher on a $1 billion investment, which is the kind of the target that we're looking for investors in this space. So we're quite excited about the opportunity to present this globally. Next slide, please. And through Victor's relationships and mine, and Peter, thank you for giving us the opportunity to host a multilateral session at Davos 2020. We're building a very strong list of potential participants. So this is a very rudimentary diagram, but you can see philanthropic funding coming in, sovereign donors coming in, a governance board, and then various entities authorizing and distributing grant funding with some country-specific implementation and some otherwise. And then the HB financing facility, we may change that to the word institute, will actually then be oversighting and managing all these particular activities. So it's a very ambitious effort. That would be an understatement to say the least, but our momentum is strong with the participants we have. Next slide, please. We are very confident that this group of people and the 50 or so people working underneath them are committed to making this a reality, and we're hoping for first rounds of funding in 2021 in the range of about $250 to $300 million in 2021 and ramping up from there. So exciting opportunity, new finance, new science, all addressed to try to bend this $3 trillion cost curve. We're quite excited about this and confident we can do so. So I will turn this back over to you, Peter.
Thank you, Garen. Appreciate it. Thanks for that information. There's a lot there. It's very exciting, a lot to unpack. One thing I do want to come back to later, just so you can prepare, is if you could speak to the way that that $11 billion return is actually quantified by the state of California. I know it's a broader societal quantification as opposed to just a financial return. So I want to come back to that. But before we do that, I do want to open up to the broader group about a key, I think, message in this global space, and especially for our audience, many of whom are innovators who are trying to understand how to plug into this global space. And that question is around the importance of collaboration and what we're all doing together. So all three of you mentioned youth as a target area and sort of the importance of coordinating there. Maybe I'll start just, Victor, with you and add another question on top of it as well, which is, I know that the National Academy of Medicine has science and evidence-based as its sort of main driver in terms of how it's trying to accomplish its mission. Right now, we're seeing a lot of mistrust in institutions around the world. And so how do you ensure that the broader public has an understanding of how important that science and that evidence base is? How do you communicate that message? And then to my earlier point, how do you ensure that that message is being coordinated among all of these different actors?
Yeah, thank you, Peter. First of all, Nicole and Garen, outstanding presentation. I want to expand a little bit of what Garen said, because we call new finance, which is clear, $10 billion, new science and new life trajectory. So the question is, how would the money be spent? And Garen pointed out there's a group called Use of Proceeds, right? And this group is thinking about how do we actually make a big difference? And I'd like Garen to talk a little bit more about this, but clearly we think about breakthroughs, we think about implementation, where there's so much known that can work that's not being implemented in the low and middle income countries. There are many other issues. So maybe I can turn to Garen first for him to expand on. It's not just a financing thing. It is what we do with the money that can make a huge difference. Garen?
Yeah. Victor, thank you so much. Yes, and absolutely right. This is, again, the purpose of all of this, right? Because we have to do this right in order to have these incomes. So we're categorizing our efforts across three major areas. Implementation science, which are places where we can actually follow along projects that we know are already working but can be implemented more quickly on a global scale for impact. Early intervention for kids at risk for psychosis is one of those areas. Potential for delivery of better treatments for ADHD with medicines we know that are more effective than those that are not working. We're also going to be working in translational science, where we'll take compounds that perhaps could be repurposed and accelerated, or other methodologies where we can bring impact on a shorter scale basis. And then we'll also be looking at the long-term basic science around biomarkers and other indicators that would allow us to get to the root cause of these illnesses, because we still need a lot more to know about structure, about chemicals, about signaling across aspects of the brain. And this team of scientists that we have working on that are working hard, meeting twice a month now in 2-hour sessions for the next 2 months. And we hope to have 3 or 4 very clearly defined project areas in early returns, longer term science and translational activities for youth-based activities well before the middle of this year, so we can start to build around that metrics that will allow us to measure the return of the reduction of disease and improvement in quality of life. So Victor, I'll give it back to you.
Okay, Peter, before I answer that question you asked me, I want to expand on this because this is so important.
Sure.
First, if you look at what we can measure quickly in disease burden, we know that if we simply practice, as Nicole said, community-based, evidence-based approach and remove the stigma, being willing to do that, you're going to see some results, I'd say fairly quickly. So that's what Garen's talking about in implementation science of knowing what needs to be done. The other extreme end, as Garen's talking about, is discovery, breakthroughs, right? A brand new way of doing things, brand new drug, whatever, technology that can really break through. And that's so important. And then in between is the capacity. Because we're dealing with a global issue, you want to be able to do the research globally and not just in US or Canada. Hence the whole idea of translation. So I think this is well thought out in my opinion. And Chris Mary's team on measuring metrics will obviously take us to task to say, are the money invested properly? Are we getting return? And not only financially, but also from a health viewpoint. I just want to emphasize that because Garen's doing a great job taking this on. I'm glad to be his partner, and I think we have a lot of opportunities. The misinformation is a real problem because, as you know, we're living right now in the month of COVID-19. And all you have to do is follow what's on, social media, et cetera, all the misinformation. So we actually need places and trusted people who's going to speak for truth, for facts, and for science-based. There are many organizations that so, certainly in the National Academy, that's what we aspire to do. We've done a lot of reorganization of community, and in fact, in COVID-19, we'll be soon having a series of webinars on a weekly basis to put out the facts and the information for people to be able to look at, aside from what's coming out from our government and others. We recognize misinformation is a big problem, and of course, we have had a recent summit with the people working this space, including Google, many other digital organizations, talk about how can we work together and how can we actually make sure that there's some kind of mechanism to look at fact-based. It is, at the end of the day, a digital technology issue. It's at the end of the day, our governance issue. I think we all recognize how important it is. And I do think that that is an absolute important issue we need to work on. In mental health, there's so much myths and untruths that we need a place where we can actually truly give out the facts and information as we're trying to do in this panel.
Great, thank you, Victor. Nicole, thoughts on coordination?
Yeah, I think it's so important. There's never enough resources, of course, but there's definitely not enough in mental health, right? It's not a well-funded area given the level of need. So being able to work together, being able to be intentional, align where we can, both not to, of course, duplicate work, and because it's the best way to be, to be able to ensure success, right? Having funders be aligned, being able to support collaboration where we can with innovators, I think that's really key. And so it's great to see when, Garen, your slide with all of the different partners that you're working with, that's wonderful. I think that's exactly what we need to be doing as a field, is really bringing everyone together to best impact on these different areas. And the fact that there's so many, I mean, it's not a surprise because we're all doing it for the same reason, I think, but that fact that there's this increased focus on young people's mental health across so many different areas and so many different groups and organizations, I think just better sets us up to be able to impact on that area.
Yeah, so I think one of the things that continues to cross my mind, and particularly for this session and in this time, is the promise of technology in mental health. We hear about this all the time. We've done at the forum, we've done a lot of work on sort of potential and pitfalls of mental health and technology. We put out a report with one of our Global Future Councils, which Murali co-chairs, on the ethical issues that are involved in scaling tech-enabled mental health interventions. Certainly we hear right now constantly on the news and from others how tech is a chance for us to stay connected during this period of what some call social distancing, which maybe is better termed as physical distancing, because we want to keep our connection. So I'm going to pivot there for just a second. I stole that from Shekhar. Victor, I see you I see you reacting here. Shekhar Saxena had tweeted that out earlier. I'm going to pivot here a little bit to the current crisis, the pandemic with COVID-19, and also just kind of the longer term benefits of things like telepsychiatry, telemedicine, community-based interventions that can be delivered digitally, etc. Maybe Nicole, I'll start with you. If you have some examples in mind of things that you've funded or that you're aware of, or general thoughts as well on the potential and the pitfalls, for lack of better terminology, of tech and mental health.
Yeah, no, I think it's very appropriate right now, but also in general, it's an area that we should be using more and can leverage. I think that one of the things that that we always keep front of mind, and that I think is so perfect for, good that you gave him credit, stole from Shekhar, is that there is the balance, of course, of being able to use technology to get services to increase screening and support supervision. But of course, the thing we're not looking for in the field of mental health is increased social isolation. So being able to use technology to change that is, I think, really key. And one of the areas where we've seen technology used a lot, and I do think that this will be changing, especially as there will, I don't doubt, be an influx of innovation and capital in virtual technology right now, given what we are all experiencing. But what we've seen a lot from Grand Challenges Canada's portfolio is the use of technology around screening and around supporting training and supervision of community health workers. Now that makes sense given the context in which we usually are funding innovation and support. These tend to be resource scarce areas. But I think that that's an area where there can be more. And I think especially building out the ability to supervise over technology, and I know that came up a little bit in the previous panel, I think is going to be key. Because we want to be able to ensure the long-term quality, to be able to also ensure long-term support. We've funded a lot of task shifting innovations, and I think that those are really important and have shown to be incredibly effective. But we also then are putting in a massive amount of burden on these lay health workers who are doing some of this treatment and care. And I think being able to support them in a stronger way and supervise them is really key. So that's an area where I see potential for a lot more support and a lot more innovation and development.
Victor, maybe any thoughts from you before I turn to Gary on the use of proceeds?
Well, actually, as Nicole is saying, if you think about technology where we are today, simply having communication and connection, the social aspect is so important. But as you know, there are people who are actually using digital device to track people, particularly for those who are more vulnerable. And let's say you take bipolar, looking at the patterns of their usage in iPhones or digital technology can really, in many ways, early detect changes in one's behavioral pattern that can cause intervention. So there are many others, and as AI and others become a lot more useful, and these, digital devices are really quite low cost and everywhere, one can imagine a real change in the way we manage these patients. Importantly, I want to speak to the 150 people who are participating in this meeting. This panel discussion about all this should mean a lot to them, because the fundamental idea of creating innovation in healthcare, in which Krishnan runs, who's one of the co-founders, is to say to all of you innovators, now this funding that Garen's putting together gives an opportunity for you guys to be innovative and come in with ideas that can change implementation, if not translation and others, right? I mean, so many of our members of the IiH are frontline innovators who've shown us that they can have creative ways of addressing, care needs. And of course, that's what the fund is for. If people come up with systematic ways of making care for the people with brain health more effectively, I would say, Garen, don't you think it certainly fits what we want to do? And it would also, as you come back to metrics, being able to show the change in disease burden.
Garen?
Yeah, absolutely. We are, the idea that we can break this traditional way of which science has been done is essential for us. I mean, we need to start working in new ways. We need to be able to look at breakthrough ideas and the funding of these through some early stage, some form of potential, something that might mirror the Dementia Discovery Fund that was put together under the auspices of Prime Minister Cameron. That's an idea that's in development as a component of the financing mechanism to stimulate new innovations. I would like to comment also on your point about technology. I mean, we have not discussed, but clearly the genome is making a huge difference in our ability to understand, because these diseases are by and large genetic mutations that are then environmentally triggered that cause these chemical imbalances. And Steve Hyman, who's a member who leads along with Miranda our Use of Proceeds Working Group, and the Broad Institute and the Global Genomic Consortium, has made incredible progress. I mean, we, as it relates to schizophrenia as an example, I think there's about 260 gene mutations, and we can screen somebody for those 260 mutations for less than $50. So that's a further confirmatory component of our diagnostic progress that wasn't available to us before. One other area of funding that we've been doing for the last 20 years, Peter, is the use of positive feedback loop, computer-based programming to take advantage of neuroplasticity. Plasticity is this wonderful thing our brain has, creating new pathways just by this conversation and all of us are listening to. And there's now over 800, I think, or maybe more than 1,000 apps trying to help people with cognitive and mood regulating disorders and memory using these apps. And we've created an independent review process called CyberGuide, PSYBER. So we're actually rating these apps with scientific evidence for both their effectiveness and privacy concerns and others. And so that's just two examples, I would say, where technology is now starting to penetrate people with these illnesses. I think I've pretty much talked about this use of proceeds area, but certainly the whole area of how we can help youth at risk is going to be our key focus here. And I'm hopeful we're going to be able to share with you these first major programs, again, as I said, by June 1st.
Great. Thanks, Garen. I have one final question, which links also to a question that a participant had asked on the Q&A function, and you guys are all welcome to continue to ask those questions. I will moderate them with the help of the IiH staff, and we'll get into that in a couple minutes. But before we do, and again, linking to one that was asked here, Garen, you mentioned, I'm going to ask all three of you the same question, but start with Garen. You mentioned this, the genetic mutations being there biologically, but then of course being environmentally triggered. And I think this is a huge component of the research that's understudied. And I think a lot of our panelists, and this is to the, our participants, this is to the question that was asked, are working in areas where those environments aren't very supportive to mental health, whether that's because of stigma or health systems or, you know, taboos or et cetera. So I guess the question is, how do we message this correctly as the research and the scientific evidence base is generated? How do we message that correctly to be sure that we don't overly step into, well, this is only a brain or genetic condition versus this is only a social determinant or an environmental question? They'll go Victor and then Nicole and then, sorry, Garen and then Nicole and then Victor.
Sure.
Well, understanding environmental triggers is where we need a lot of work. Let me start with that. We do know that things like serious illness in the second trimester of pregnancy can be a restriction in blood flow or disease burden that happens at that time, and that is very likely a environmental trigger. Stress and other social conditions, particularly abusive childhood, difficulties there, which also has some certain economic and societal issues that go along with that, are also factors that we know exist. But the relationship with how these environmental triggers then precipitate the illness itself is still not very well understood and a real area for our study, Peter.
Yeah. Nicole?
Yeah, I agree with, of course, everything Garen just said. And then just thinking, so taking it to a slightly different area, like, you know, different, say, implementation and work area, I think it's important to be mindful that not every, you know, that there's no one size fits all, that the context in which, you know, these different innovators are working or these contexts in which we're looking to educate people are different, and being responsive to that, being aware of cultural norms and differences that exist and adapting to that specific context is really important. And I think that part of that is also just being open and upfront about, as Garen says, things that we don't know yet, and trying to educate on areas where we do. And so one of the things that, you know, Grand Challenges Canada is doing is that with our youth funding call that's going out in May, we'll be also looking at mental health literacy programs and being able to innovate in that space as well, is that how we do educate people and how we can work with communities to try and be supportive in this area is also a space that is right for innovation.
Yeah. Victor, last word before we turn to our audience for Q&A.
Well, I think you said it all. I mean, this really shows how these are interlinked, connected, and, you know, multifactorial. And I think if we're to expand or extend what Garen and Nicole said, I would say, think about family members and the environment in which you live. Yeah. And because these matters a lot, think about understanding the brain biology. You know, what is it that an underlying genetic disorder can influence your brain growth and your response? What is it that environmental factors such as social determinants influence the brain growth and others? And what is it about the triggers? At the end of the day, it's mainly the brain biology. And understanding this, to me, is where the breakthrough is going to make a huge difference. So we need to bring all these things together, and we need to be able to find the right answer to these questions.
Agreed. Thank you all so much. Let's turn to the participants for a bit of a Q&A here. We only have about 10 minutes. I know there's been some chatter on there, but I'm going to look to Krishna and Judd to see if there's other things that we haven't addressed yet. Otherwise, we can go to some other questions for the panel.
Sure, thank you. I'll stay off camera here, but you can hear me. I think this is Krishna.
You can come over here if you want.
6 feet, Victor, 6 feet.
Here. But no, thank you all for a fantastic conversation so far. I think one question that's come up from the audience is this idea of many of the folks that are here that are working in this ecosystem are also addressing poverty and operating in low resource and low income environments. So especially when you think about this intersection of poverty and health, certainly including mental health, how does that influence your thinking and what changes when you're also trying to address poverty in addition to mental health?
Yes, Victor, go
I just want to emphasize equity. No matter what we do, our research and our decisions will address the issue, or at least be sensitive to the issue of equity. And poverty obviously is a big issue in this regard, as is many other factors. But I want to emphasize the issue of equity.
Tell us more, Victor. What can we do, those of us who are working either kind of systemically or as innovators on the ground, to ensure access of the same types of healthcare to different communities, et cetera?
So many of the things I've been involved with, such as CEPI, as you know, another organization co-founded by World Economic Forum and others, as one of them. I think the issue of having access, having essential medicines, having vaccines that everybody can have, and therefore the issue of pricing and all those things need to be addressed. And so in that regard, when we think about our area, which is what we're talking about today, and I know Nicole thinks about it all the time, I know Garen does for sure, that we want to make sure that whatever we do is actually for everyone and not just for those who are privileged.
Yeah. Nicole, I know that Grand Challenges Canada really prides itself on, how, well, every organization talks about impact and monitoring and evaluation in their own sort of language and everything. But speaking from an organization that is within that space as well, I understand how those definitions can change and can be quite specific to the organization. When we're talking about actually changing people's lives on the ground and what that means, tell me a little bit about how you, as Grand Challenges Canada, go through that sort of M&E monitoring and evaluation and impact evaluation process.
Yeah, absolutely. So each of our main outcome measures that we look for at Grand Challenges Canada are lives saved and lives improved. And each of our different challenge areas have their own results monitoring framework that we've developed with the help of our scientific advisory committee, with a number of different stakeholders that we've engaged with over the years. So for global mental health, we have a very detailed and rigorous framework that we look for in terms of what the data that we are gathering and that we ask our innovators to gather. And when at the beginning of each grant that we put out, we work individually with that innovator, with our knowledge management team, to set specific targets for them, specific to their program. Things that we look for include changes in symptom severity, changes in level of functioning, level of quality of life, overall well-being. We have different measures that we recommend are used for that, and we support our innovators to be able to track and collect data on that. We also look at different more immediate measures. So how many, say if you're looking to train, how many individuals have you trained? How are you managing this? How many different facilities are perhaps implementing this innovation? What kind of community engagement work is being done? How many people, are there changes in knowledge and stigma? So there's a number of different ways that a number of different metrics that we look for, and a number of different ways that we measure those. And then we collect data we support our innovators and collect data from everyone as projects continue and we're able to align across the portfolio. And then we have our impact modeling, so we can project outwards. And that's done with a framework that was developed in partnership with the International Development Innovation Alliance of how we can project these things. So I know that, if you look at our website, we have projections for how many individuals our innovations will be able to support by 2030. And so we do each of those individually, taking a really conservative approach so we can, be sure that we're not overshooting things here, but looking at pulling in literature, pulling in different sort of feasibility estimates, mapping out a number of different scenarios to be able to project outwards. And I think one of the things, as you mentioned, a number of different organizations look at this, and everyone says things, everyone's got the kind of their own different approach. And so we really look at these as living documents, and we regularly re-engage with innovators to even, a year, 2 years after we stopped funding, to be able to check in and see where they are and continue to update those numbers.
Yeah, it's super helpful. And from my perspective, it makes a lot of sense to have this kind of mix of, theory and academic, research that goes into impact evaluation, as well as involving the innovators and the local communities for whom you're working. So I wish we would all do a little bit more of that. So we're coming up on time. I'm going to give each of you a last word. Garen, there was a final question that talked about the future of mental health and how multi-sectoral or intersectional it is. And I know as somebody wearing a number of different hats in the global mental health space, you have a very good handle on how this all fits together. So I'm going to start with you for that question, and then ask you and then each of our other panelists to discuss some things that they're doing right now to manage their own mental health during this pandemic. I will be glad to share my thoughts on that at the end before I turn to Krishna. So let's go, Garen and Victor, and then Nicole, and then we'll wrap up.
All right, on that first question, I think, look, these diseases don't know any economic, gender, racial barriers. They are the same. The incident rates are the same across the world. So we must think of it as a global problem. My dream is that we will start to think about brain health as a spectrum that we are all on at any one point in time. Victor's going to get on an airplane. He's going to have a lot of stress, worried about COVID. When he gets back to his home, his mental health, his brain health is going to be different than it was had he just had 8 or 9 hours of sleep. So the whole area of stigma and discrimination, I'm hopeful will be changed by our attitude of understanding brain health as a spectrum. And the work that we're doing will lead to better diagnostics, better treatments that will ameliorate more than just symptoms here within our lifetime. I'm excited about how this new financing approach will accelerate it. As to how I'm coping with anxiety, first, grandchildren are great for that, so they keep you happy and completely distracted. And I think most of you know I'm in the wine business, so a great glass of Cabernet is always food for thought and food for comfort. Yes.
Victor?
Okay, so first of all, I didn't want to not address the poverty issue. I think equity is important, but I would surely say that we recognize, of course, these social determinants are so important that we have to address them. So in the work that Nicole and other people are doing, I know they are, and certainly in National Academy, we're very much into the issue of social determinants, and job poverty is an important one of them. And I know that Garen and I, as we look forward to launching this whole initiative, that we pay attention to how to address this issue. It's a very complex socio-economic issue that, of course, well beyond any of our capability, but nevertheless, we can certainly look at the environment in which it creates and how that is affecting mental health. And certainly, we do know that in the early ages, this is going to have a tremendous important effect in development of the brain with regards to early childhood and others, and how this will in fact be addressed. So I just want people to know that this is very important to all of us. I know that for a fact from my colleagues. So the issue of the COVID, I would say that I've been extremely occupied. And Garen, I'm sorry that I didn't have much time because we're raising $8 billion for COVID through GPMB. This is the Global Preparedness Monitoring Board. And in fact, yesterday we were in touch with Macron and with von der Leyen, and they are G7 today discussing a proposal among many others. So we need the money urgently. For myself, I think, first of all, I'm so glad the Academy's decided to let everybody work remotely. I think we need to think about the health of everybody, and the issue of physical distance is important indeed. For myself, actually, I tell everybody now suddenly we have more found time because Gary and I were on the plane a lot. And now suddenly, anybody who says no to me, I said, come on, you're not traveling anymore. You have more time, right? And more time to read, more time to think, more time to write. And guess what? My wife and I played 9-hole golf yesterday morning at Hope Valley. And because nobody around, there's the two of us, it's great social bonding in playing golf. And even though we're not quite 6 feet apart, I think some of the time we were, because I was playing so badly, she was way ahead of me.
Well, thank you, Victor. I'm glad that you're finding some time to do some of those things because clearly there's not that much going on for you this at the moment.
Not true.
Nicole, final word?
Yeah, I am definitely not as busy as you are, Victor, with coordinating all of these different global leaders and support around getting this financing out. And so happy that you're doing that for many reasons. Coping with my own mental health, I think it's really taking it day by day, recognizing that this is a very anxiety-provoking situation, and so all of these feelings are, and stress is very normal and expected, and just trying to be really cognizant of that, and still, as both Garrett and Victor said, making time for things that bring me joy, make me happy. I'm reading a lot. I've done a number of things that doesn't look quite like this with this many people. As part of it as I look down at the participant number, but I've set up quite a few virtual coffee and dinner dates with friends, and I think I'm going to keep doing that and keep making space for that as well.
I think Garen should send us his wonderful wine to every one of us.
That would help my mental health
sit back
significantly.
and relax. Hey, Garen?
You have to talk to the CEO, my wife. She's the one in charge of donations.
Tell Sherry I'll give her a call in a few minutes.
All right. Okay.
Well, listen, thank you to all the panelists. I know from my side, as somebody who's dealt with a lot of mental ill health over the years, this is, obviously, as you say, Nicole, a really anxiety and fear inducing time. And I think your advice of taking it day by day, managing the type of information and how much you're consuming, that's good advice. I think that the last thing I would say, just from my own personal experience, is I'm a pretty emotional guy. I have a lot of ups and downs anyway. So leaning into those and sort of, as you say, making sure that I'm kind to myself about what those mean and kind of leaning into those feelings has been super helpful to me. Luckily, this is not day one of my own journey with my mental health, so that makes a difference. Thank you so much to all of you, Krishna and Judd and the organizers. Thank you so much for pivoting on a dime like this. It was really impressive how you've kind of turned this around in such a short amount of time, and I really appreciated how you reached out to all of us to ask our opinions about what to do with this conference as opposed to making an executive decision. With that, I will wrap up this panel, turn it back to you, and say thanks everyone one more time. Appreciate it.
Fantastic, thank you, and Peter for fantastic duties in moderating. Also to Victor, Nicole, Garen, thank you all for a fascinating and fantastic conversation. I know it was much appreciated. This really closes our first day. Just a few thanks. Thank you to everybody for hanging in there. As Peter noted, this was all done on a dime, and we created this whole digital experience in the last week. So a huge amount of thanks to our team here to make it all work, and for everybody to come along on this journey and experiment with us. A quick note, we know we got many more questions than we were able to answer in real time. We will try to curate the questions, get answers from each of the speakers and panelists and get those back out. Please do continue to rely on the Whova app to stay engaged with each other. Again, we know that there's limited interactivity, which is such a valuable component of this community being together. So please try the Whova app to see if we can keep some of these conversations going. And finally, please rejoin us. We're starting again at 9 a.m. sharp East Coast time tomorrow. Thank you to everyone. Have a great afternoon, evening, and night, and talk again soon.
Thank you. January.